All right, gang, this is a big topic, endocrine system. It's very high yield because a lot of physio. So we're going to remind ourselves of a lot of physio. So let's start with some basics, some background. For endocrine system, we're going to have signaling, and there's 3 different types of signaling we can do. Okay, let me draw a cell, turn my tools on. Okay, so here is the cell, and it wants the signal. Well, who can it signal? It can signal itself. It can signal itself. That's called auto, myself. Autocrine, stimulating itself. It's kind of like masturbation. So don't look, unless you're into that, don't look. The cell is turning itself on. So like T cells will do this. They'll make interleukin 2 and it will stimulate themselves. So that's called autocrine stimulation. Now, what if there's a cell next door? Well, I can signal that cell too. It's right next to me. So para means next to. Para me, next to me. So paracrine is when you signal somebody next to you. That would be kind of like waking up in the middle of the night and say, honey, I'm in the mood. Honey, I'm in the mood. So you turn on the cell next to you. So self-stimulating, stimulating the one next to you. Now, what about endocrine? Because that's what we're going to cover in this chapter. Endocrine, well, that's signaling somebody far away from you, way far away. So, what would that be like? Signaling somebody far away from you and turning them on. Would that be like sexting? Or for you guys, Snapchat, baby? Snapchat? You send naked pictures to each other and they disappear? So that's signaling from a distance. That's endocrine, and that's what we're going to talk about here. Cells releasing chemicals that go downstream, and then they affect an organ. They turn it on. Now, there is a problem with sexing. There is. If you sex somebody too much, you kind of get like bored of it. It's like, okay, that's enough. So unfortunately, if you give too much hormones long term, there'll be some down regulation. Yeah, you can kind of get bored of it after a while. You want the real deal. It's like, stop sending naked pictures and come over already. Who do you call? Man, if I make everything naughty, you'll remember it. You'll get like a 2000 on the USMLE. So we're going to talk about endocrine signaling now. Now, 2 ways we can signal. We've got water-soluble hormones, and we've got lipid-soluble, 2 different categories. And again, this is some basic biochemistry. But for water-soluble, we have examples of like growth hormone, we classic, insulin, epinephrine. Now, where are they synthesized? Well, they're protein hormones, so they're synthesized by the rough endoplasmic reticulum. Now, can we store these? You bet. You'll store them and release them when you need to. So cells can store them in granules and then release those granules when they want to get an effect. Now, does it bind to plasma protein? It doesn't need to. It's water soluble. It can dilute itself and float around in the plasma. Doesn't need anybody to carry it. It can swim on its own. Now, receptor location. Since it's water soluble, it cannot enter the cell. It can't. It's got to stay in the plasma. So therefore, there must be a receptor on the surface of the cell. There's got to be a receptor here for it because it can't enter the cell. So it's in the plasma, and it will float over and bind to its receptor. Okay, so storage gets released into the plasma, and for the plasma, it will find your cells and bind to the receptor. Now, the receptor has to bring the signal in. It's got to be signal transduction, secondary messengers, and this is a favorite for USMLE. For every receptor there is, they want to know how does it bring the signal in. For instance, they've asked the insulin receptor, how does it work? You guys remember how the insulin receptor works? That's one you must know. Does it work with cyclic AMP? What does it work with? Remember? Yeah, it's a tyrosine kinase. It uses tyrosine kinases, that phosphorylate tyrosine residues, to turn on things inside the cell and bring the cell inside. Bring the signal, I should say, the signal inside. So they always want these secondary messengers. Does it work with a G protein? Is it GS? Is it GI? Is it GQ? Does it work with cyclic AMP? They really like to test it. I know it's not sexy, but it's molecular biochemistry. How do receptors bring signals in? All right, now the other category of hormones we have are these lipid-soluble hormones. These are things like steroids, estrogens, progesterone, glucocorticoids, vitamin A, thyroxine. These are all lipid-soluble. Now, where are they synthesized? Well, that's a little different. They're steroids or steroid-like hormones. Therefore, they're going to be synthesized by smooth endoplasmic reticulum. And so the cell that's making them needs a lot of smooth ER. Now, can we store lipid soluble? Let's see. If I put lipid soluble inside a membrane-bound vacuole, it'll go right through the lipid membrane, leak right out. You can't store them because they're lipid soluble. They go right through the membranes. So we can't really store it. The only one we do store is thyroid hormone. That's kind of like an exception to the rule. Do you remember the follicle cells? You have these follicles lined by follicular cells, and they're going to secrete it and store it inside the middle of the follicle. This stuff will be called colloid. Colloid, this pink stuff in the middle, colloid. Now, colloid is made of thyroglobulin. That's how we store our thyroid hormone. And then you can cleave it and release it into the cytoplasm. But it's going to be stored. It's the only fat-soluble one we're going to be storing in a cell. So where's the storage? If it's not inside, where are we going to store it? Well, it gets stored in the plasma when it's bound to binding proteins. So basically, steroids are made and they go right into the plasma, and they have to be bound because they're not water soluble. They won't float. So they have to bind to a carrier. We call these plasma binding proteins that are going to carry it. And those are going to act like the storage pool. So here's the hormone. The hormone in my plasma has to be bound to something. So I'm gonna make a binder here. So I'm gonna make it bound to a binder. So this is a binding or carrier molecule that's gonna carry it around. Now, if it's bound, it can't float into your cells and work. So this is always in equilibrium with some free hormone. So basically, we have two pools. We've got most of our hormone that's floating around bound, and there's a small fraction that's going to be free. And that's the fraction that can go across the membrane and make a growth signal. So when we measure things like thyroid hormone, we're going to want to know the free fraction. We don't care about the bound fraction. That can't work. That's bound, it's circulating around, but it's the storage. So this is our storage. Then it gets released in the binding protein. Now it's free. Now it can go into a cell. All right, so always focus on the free fraction of lipid hormones. The total doesn't matter. It's the free fraction that matters. Now, how does it work? Well, its receptors don't have to be on the membrane because it can go through the membrane. So these are going to be either in the cytoplasm of the cell or in the nucleus. That's where the receptors will be because the hormone can just migrate right through the lipid membranes inside. Now, when it binds to either cytoplasmic or nuclear receptors, these will go into the nucleus and either bind to promoter regions or enhancer elements. And that's what will turn on the DNA, and you get growth, growth, growth. That brings the growth signal in. All right, so very important, we have this basic foundation. Water soluble need receptors, they need signaling. Lipid soluble, there's no storage pool. The storage pool is basically the plasma bound fraction. And it gets released, the free fraction is what's active. It goes in and it binds to its nuclear or cytoplasmic receptors, which directly interact with DNA, and they turn on genes for growth. All right, so that's a big picture, some foundation. Now, let's talk about our endocrine organs. We're going to go one after the other, after the other. We're going to start with the pituitary, talk about all the normal and the abnormal, and we'll do thyroid and parathyroid and pancreas and adrenal, and finally pineal gland. Out of all these, the lowest yield may be the pineal gland in terms of questions for exams, because they love pituitary, especially the tumors. They love thyroid. There's so many thyroid questions. Parathyroid's on the lower end of the yield. Obviously, pancreas is high yield because diabetes is huge. And adrenal, they love adrenal. So notice why this chapter is high yield. This is high yield, this is high yield, this is high yield, this is high yield. Wow, we definitely need to know this. Now, for big picture, what's the pathology we're going to see in these organs? Well, really, there's three big pathologies. For endocrine organs, we look for disorders of hyperfunction, where they make too much hormones and you get a hyper effect. The opposite can occur. You can damage it and you can get less hormones and get hypofunction. And then finally, they can get tumors. Of course, for pathology, that's very important. Tumors. Those tumors will produce mass lesions, which can destroy the rest of the gland, and of course, destroy neighboring organs and metastasize potentially. All right, so for every organ, we're going to go through in this list. We're going to talk about hyper, hypo, and mass lesions. Now, one more rule of thumb. Rule of thumb. If there's a hyper-functioning gland, What do you want to try to do to it? Well, if it's hyperfunctional, I want to see if I can suppress it. So we're going to do suppression tests here. Okay, so if it's hyperfunctional, let's do suppression tests. See if we can shut it down. Very important for diagnosis here, doing suppression tests. Now, what if it's hypofunctional? The organ is just not working. Let's stimulate it. Let's do stimulation tests, see if I can get it to work. Stimulation tests. Okay, well, that kind of makes sense, right? So if the gland is hyperfunctional, see if you can suppress it. If it's hypofunctional, see if you can stimulate it. Makes sense. So we'll talk about stimulation tests, we'll talk about suppression tests. Very interesting. Now, this entire chapter is devoted to the amazing, fantastic, wonderful women that are in our lives. Women are truly God's gift, right? So we're going to dedicate this chapter to them. Now, the reason why is almost every single lesion is more common in women. Now, men can get it too, but women get it more commonly. Ladies, you should share. Keep all these interesting diseases. Well, men can get them too, it's just less common. So we're going to dedicate it to women because women are fantastic. They're unbelievable. And most of these things occur more in women. Now let's get right to it. Let's talk about the first gland on that list, which is the pituitary gland. Oh, there's so much here we can talk about. Now there's two parts of it. We've got an anterior pituitary, which is a rather large section of the gland. And then we have the posterior, which is much smaller. And we call this the master control. Master control. See, right above it, hypothalamus. The master control is right above it. So hypothalamus is the one that's going to control this pituitary gland. So pituitary may be the master gland, but the master control is the hypothalamus. It controls the pituitary. Now, why is the posterior so small? Well, because it doesn't make that much. Look, it only makes two things, oxytocin and ADH, which is vasopressin. Now, notice it's connected to this master control by the stalk. In fact, the neurons are up here in the hypothalamus. There's their cell body, there's their nucleus. Then they come down the stalk, their axon comes down the stalk, and then they can release their chemicals right here. They'll just release their chemicals. So the chemicals are actually made in the hypothalamus, then they travel down the axon, and they get released in the posterior pituitary. So that's what ADH does. It comes down the stalk, and so does oxytocin. So notice, the anterior pituitary is not really attached. It's just sitting here, sitting next to it. So if I damage the stalk, you're only going to have problems with the posterior pituitary because the neurons are coming down. And since these neurons are coming down, we sometimes call this the neurohypothesis. Neuro, because the neurons are actually coming down from the hypothalamus and they're emptying their products here. Now, good news for you. There's actually no diseases of oxytocin. None. Yes! There's no pathology of it. So then what could they ask about it? Well, they could ask, as a clinician, when would you use it? Well, let's see. What does oxytocin do? It contracts muscle. It'll contract it in the uterus, and that will induce labor. It also contracts the muscle of the breast, the ducts, so it can express milk. So it's important for breastfeeding, for lactation, because it'll contract lactation. Well, which reminds me, when a baby cries, the mother hears that, the brain actually releases some oxytocin, and you'll see a little bit of a discharge will come out of the nipple. As soon as the baby cries, they feel it. They feel it's because the contraction. The body is designed so amazingly, right? They hear the crying, oh, baby must be hungry, and the brain tells the breast to start secreting. Wow, fantastic. Now, as a physician, how can we use this drug? We can actually make it into a drug and use it. Well, we can use it to induce labor. And so if you want to have somebody induce a labor, get the baby out, you can start an oxytocin drip, and that will start contractions of the uterus. Another use is after the delivery. After the delivery, the baby came out, the placenta came out. Now, the uterus should now contract and then squeeze the vessels so the bleeding stops. If the bleeding doesn't stop postpartum, well, there's two things we can do. We can manually massage the uterus from outside, just manually massage the belly, the uterus, squeeze it, and that can cause the muscle to contract. Or you can continue the oxytocin. So give them another bolus of oxytocin, and that will cause the uterus to contract, and it will stop bleeding, postpartum hemorrhage. All right, now another use for it, is it labor, anything else? I'm trying to think of what else we can use it. Those, I guess, would be the two major uses clinically as a physician. All right, now what about ADH? Well, ADH is very important because we have diseases where it's too high, that's the syndrome inappropriate ADH excretion, and we have diseases where it's really low, that's called diabetes insipidus. And that usually occurs when the stalk gets injured. You injure the stalk, ADH can't come down, you get diabetes insipidus. All right, now the anterior gland is much larger, but it doesn't need to be connected to the master control gland, the hypothalamus. Basically, where it came from embryologically is epithelium from your mouth. You have tooth epithelium, epithelial cells from the mouth. They actually migrate up and they form the anterior pituitary. So it actually comes from your mouth. Isn't that interesting? It comes from your mouth. So this one came from your brain, the neurons growing down. That's the neurohypothesis. The adenohypothesis, the gland, this one came from your mouth, and then it comes here. Now, do you remember what it's called if there's a remnant of epithelium? A little remnant of epithelium right here, you know, right near it, like supracellular area, this remnant, we call that Rathke's pouch. That's a little piece of tooth epithelium from the mouth, and that can actually become a tooth tumor. You can get a tooth tumor right there. That's called the craniopharyngioma. They occur right above the sella caturcica, right above the pituitary, supracellular area. It's just a remnant. Interesting. Now, this anterior is much larger because it's making a lot of products. So we call this the adenohypothesis because it's like a gland making a lot of stuff. It's a master gland. So it's making TSH, it's making prolactin, it's making ACTH, growth hormone, FSH, and LH are gonadotropins to stimulate your gonads. So this is a gland, this is like a master gland, and it's controlled by the master control, the hypothalamus. All right, now let's talk more about some of these and the regulation of it. The regulation, because what regulates everything is the hypothalamus. So it's going to regulate the secretion of most of these chemicals. And the way it does it is by releasing hormones. So it's going to actually release hormones that will go through your bloodstream and will stimulate the gland, the anterior pituitary, to make its hormones. See, there's no axon coming down here. This is an endocrine process. It's going to release it from the cells here, and these releasing hormones come down here and stimulate the pituitary to make all these hormones. Now, to make thyroid hormone, we're going to produce thyroid-releasing hormone, and it's going to have a positive effect. It'll stimulate the gland to make TSH. That'll work on your thyroid. Now, the next one is interesting, prolactin. Prolactin, the gland always wants to make it. It just wants to make it all the time. So what the hypothalamus has to do is it has to stop it. It has to actually negatively inhibit because the gland wants to make it all the time. For TSH, you have to stimulate the gland to do it, but it wants to make prolactin all the time. So what does the hypothalamus make? It makes prolactin inhibitory factor, better known as dopamine. Dopamine, it's got a negative effect. So basically, you need the hypothalamus to prevent prolactin from going sky high. Interesting. And whenever there's a negative effect, the board loves it. They love negative stuff. Now, how is this important for me? Well, what if I give a patient a drug that's a dopamine antagonist? Well, if you give a dopamine antagonist, you're going to knock out the dopamine here, and now you're going to get hyperprolactinemia. That is very common. So whenever I give a drug that's a dopamine agonist, you will get high levels of prolactin. That should not be surprising. Now, let's do vice versa. What if I had a tumor of the pituitary that was making prolactin in high levels? How could I inhibit that anterior pituitary adenoma from making prolactin? I would have to give high levels of dopamine or dopamine agonist to stop the tumor from making a lot of hormone. It's so cool. So we can use it for tumors. All right, now the next one is ACTH. Well, to get that to be stimulated, we have to make corticotropin releasing hormone. That will tell the pituitary to make ACTH for the adrenal gland. All right, now let's come over here. Growth hormone is fascinating because it's got both positive and negative regulation. So it can be positively stimulated and it can be inhibited as well. Now, to make it get secreted, we have growth hormone releasing hormone. That makes sense. Growth hormone releasing hormone, that's from the master control, the hypothalamus, will stimulate the gland to make it. But we can also inhibit it too. We have growth hormone inhibitory factor, better known as somatostatin. This is an inhibitory hormone that will inhibit growth hormone. So it basically is a balance. How much stimulation for release versus how much inhibition, that will determine your growth hormone level. And remember, it also fluctuates during the day. It fluctuates. Like in the morning, it's like really hot. So it's going to fluctuate throughout the day based on the positive and negative regulation. Now, again, what if I got a tumor of my anterior pituitary that started making growth hormone? Okay, if the tumor's making growth hormone, I could inhibit it by giving analogs of somatostatin, something like octreotide. Octreotide should be able to inhibit it. And then finally, we have gonadotropin. Gonadotropin releasing hormone that will tell your pituitary to produce the gonadotropins, which are FSH and LH. So most of the time you have to stimulate the gland to make stuff. You have to stimulate it. But whenever there's negative regulation, they like that on exam, because we can actually use it to negatively inhibit tumors. So dopamine will inhibit prolactin, somatostatin will inhibit growth hormone. That's going to be very testable. They like that. All right, now let's take an actual look at what these cells look like. Here is a normal pituitary gland. First thing I want you to notice is the cells here are kind of grouped. They're grouped. See this reticulin, this fine reticulin connective tissue? It's basically dividing them into these nests of cells by this reticulin framework. This reticulin network is dividing the cells into these nice groups or nests of cells. So that's normal. We should expect to see a nested pattern of cells when we look at a pituitary. And again, I'm telling you that for a reason. It's going to get lost when there's a tumor. So very important to notice that reticulin network. Now, when I show this picture to my niece, she goes, oh, it's pretty. It's pretty because there's different colors. We've got cells that are really dark blue, and then we got cells that are more red. They're more pink or red. So there's a variation in cells depending on what hormones they make. Some hormones are going to make the cytoplasm very red. Some of them are going to make it very blue. All right, so when they're red, like this pink guy right here, it's nice and pink, he's eosinophilic. Another name for eosinophilic is acidophilic. Acidophilic is eosinophilic, pink. Now there's only two cell types that will be pink. Somatotrophs, those are cells making growth hormone, and lactotrophs, lactation, those are the ones making prolactin. So it's these hormones that make it look pink. They're very high in protein, they're very pink. Now, how can I remember that? Well, let's see. If you turn red, you should go see your GP. You should go see your general practitioner, right? If you turn red, that's not healthy. If you turn red, go see your GP. That's one way to remember it. Go see your general practitioner, GP, growth hormone, prolactin, eosinophilic, they're red. Now, what about basophilic? These ones that are really blue. Those are kind of really pretty. We call those basophils or basophilic cells. They're blue. Now for this, it's going to be corticotrophs, which make ACTH, thyrotroph cells, which are TSH producing, and gonadotroph cells, which make LH and FSH. Again, it tends to be a lot bluer. Now, how to remember this? Well, if you're singing the blues, how about using B flat, basophilic flat, B flat. You're singing the blues, B flat. So flat, FSH, LH, ACTH, TSH, flat, FLH. Does that work? You're singing the blues, how about B flat? B flat blues, B flat, B flat blues. Wow, that's like a tongue twister. So I'm just trying to give you ways to remember in case they point to a cell on the exam and say, hey, this one's blue, which cells could it be? This one's pink, what cells could it be? You'll have a differential. All right, now, what if it doesn't make much hormone? Oh, if there's a cell that doesn't have much hormone, it's not gonna have much color, is it? No, it's not gonna have much color. So if you take a look at this cell right here, this cell really doesn't have much color. How about this cell right here? This cell doesn't have much color either. How about this one? Not much color to those cells. So they call those chromophil cells. Chromophil. Chromophobe. Chromophobe. Phobe means you're afraid. So chromophobe, they're afraid of color. Chromophobe cells. It's just a cell that didn't make a lot of hormone. Okay, that's a chromophobe. It just doesn't have a lot of hormone. All right, now let's talk about the big pathology here. The big pathology are pituitary adenomas, benign tumors of the pituitary. But obviously anything in the brain could cause problems. If it grows quickly and pushes on things, you can have big problems from this. So even though they're benign tumors, they're in your brain, and that's never a good thing. Now in general, it's usually middle-aged people who get it, so 30s to the 60s, middle-aged people. And we're gonna arbitrarily classify it two ways. First way is just based on size. And I don't know why, but they pick 1 centimeter, just arbitrarily, 1 centimeter. So if it's smaller than a centimeter in size, we call it a microadenoma, small one. If it's bigger than a centimeter, bigger, then we call it a macroadenoma, just based on size. Obviously, if it gives you a lot of symptoms, you're going to come in early and you're going to find it small. If it doesn't give much symptoms, like doesn't make a lot of hormone, then it'll present later and become much larger. Make sense? So it just is the size. Size does matter here. Now, second way we're going to categorize it is based on its function. Is it functional or is it non-functional? Functional means it's making some sort of hormone. And we can classify the tumor based on what hormone it makes. How do we know which hormone? Well, from the symptoms, but also from immunohistochemistry. So if here's a tumor, we can stain it. We can say that this brown stuff is the stain. So see, this cell is lighting up with the stain. These cells are lighting up. You see the nucleus in the middle? These cells are lighting up. There's a group of cells. So these cells are positive for the stain. Now this stain just happens to be growth hormone. So what kind of tumor? Well, it's going to be a growth hormone producing adenoma because it's got growth hormone in the tumor cells. So they all have growth hormone. This is a growth hormone adenoma. Makes sense. Now, when you have a lot of growth hormone released into your blood, you're going to get symptoms from that. That's called hyperpituitarism. You're having too much hormone release, and therefore you're making something. Now, this is usually due to an anterior lobe adenoma. That's the most common cause of hyperfunction of the pituitary. Question, could the pituitary hyperfunction if the hypothalamus overstimulates it? That's another reason too. So you can have hyperpituitarism from hypothalamus problems too. But most of the time, it's an adenoma making too much hormone. Now, another thing it could do, aside from giving you hyperfunction, it could give you hypofunction. How can it do that? It can squish the rest of the gland. The tumor can literally squish the rest of the gland and knock it out. You get hypopituitarism because of the pressure causing atrophy. It's basically what's called a mass effect. You're just squishing everything. So a tumor, if it's small and making hormones, gives you a hyperfunction of the gland. If it's larger, it'll crush the remaining gland, and those hormones, the other hormones, will be lost. All right, now one more category, and that is non-functional. Functional makes stuff, non-functional doesn't make anything. So these tend to be very large tumors by the time you find them. And when they get large, they definitely destroy the gland, and they push on the rest of the brain too. And they cause more mass effects on the rest of the brain too. In fact, let's talk more about that. What kind of mass effect can I have from a large one that's usually non-functional? Let's take a look. Okay, look at this brain. Here's the brain. Notice, this is the pituitary adenoma. Is it well circumscribed? Oh, yes. You can easily see where it starts and stops. These are benign tumors. Well circumscribed. Look at the size of it. Holy, this is like the adenoma that ate Pittsburgh. This is a monster. I mean, clearly it's squishing this poor dude's brain. It's squishing it. It's pushing it over, squishing it, squishing the ventricle and everything. That's a pretty big tumor. What did it do to the silica turcica, the bone? Probably enlarged it and eroded it, right? So if we did radiology on this, we're going to see a sella turcica that's been expanded. Yeah, so instead of being a nice little silica turcica like that, we're now going to see one that looks like this. Wow. Because the tumor is going to erode the bone. So that's a good clue on x-ray. When we do an x-ray or a CT, you'll see the enlargement of the sella turcica. Now, as it goes up, do you guys remember above the pituitary? Normally, if here's the pituitary sitting here, above it is the optic chiasm. The crossing fibers are right there. So if this tumor gets very large, not only will it erode the bone and make this cell go large, but it can go up here and push on that. Now, when it does, you're going to get what's called a bitemporal hemianopsia. It's beautiful. You're going to lose vision in the peripheral. So how would the patient present if they lose their peripheral vision? Well, I can still see in front of me, I just can't see to the sides. So car accidents. That's how they often present, car accidents. And they bump into stuff because they can't see stuff coming from the side. That would be classic. So they kind of like this, even though it's not very common. But if you have a large tumor moving up like this one, they definitely had some visual field problems because it's going to push on that crossing fibers, optic chiasm. Now, with a big tumor pushing on the brain, it's going to increase the cranial pressure. So getting a headache, oh yeah. Nausea, vomiting, sure. Maybe even papilledema because of the high pressure. Now, something that's very interesting about pituitary tumors, they can bleed into themselves, just spontaneously. They can just bleed. And that will cause what's called pituitary apoplexy. I find this fascinating. Pituitary apoplexy. This is when the tumor bleeds into itself acutely, so you get acute hemorrhage into the adenoma, and that will certainly squish and destroy the gland, but it will also, the bleeding will cause enlargement. It'll cause enlargement in this area because the blood will get bigger and bigger. So the tumor will rapidly enlarge and cause herniation. It'll herniate. If my thumb blows up, no big deal. If something in my brain blows up, my brain has not much room. You're gonna herniate and die. This is literally a neurosurgical emergency because the rapid blood bleeding is gonna cause a rapidly enlarging mass, which will cause pressure. Not cool. So these tumors can bleed into themselves. I've actually seen a couple of cases where the tumor bled into itself just a little bit, enough to kill the tumor, but not enough to kill the patient. So basically the tumor killed itself. Fascinating. But again, that's a limited bleed. If it's excessive bleeding, you will die from a rapidly expanding mass. Pituitary apoplexy, remember the term. All right, now let's talk about some genetics of adenomas. If they're a tumor, even though they're benign, there must be some sort of genetic thing stimulating them, right? Tumors just don't happen. There's got to be some sort of gene problem. Now, for adenomas, I want you to remember GS, G protein. GS, the stimulating one, right? Stimulating. GS protein mutations. They occur in about 40% of growth hormone producing adenomas and a smaller percentage of AC or TH adenomas. Now, here's why. Take a look here. The receptor here for not only growth hormone, but also corticotrophin hormone, both of these are going to work through G proteins. This is the G protein I'm outlining right here. So the receptor brings its signaling through G signaling, G protein. This is a GS. And G proteins have two subunits. They've got an alpha subunit and a beta gamma subunit. Now, normally it's in the resting state, which has GDP. It's got only two phosphates on it. That's resting. When it gets turned on, it gets another phosphate. So now it's GTP bound. So that extra phosphate turns on the G protein. Now this G protein is going to start sending in the signal. Here's the way it does it. The alpha subunit will turn on adenylate cyclase, which turns on cyclic AMP, and that's what tells the cell to proliferate. It tells it to proliferate, and the adenoma grows. So let's repeat. It's supposed to be in a 2-phosphate GDP state. Then it gets phosphorylated. The 2 comes off. The 3 is now on. Now you got 3. That's what causes the signal to come to the cell. Now, if this signal stays on forever, you're just going to grow and grow and grow. Normally, what we need to do is shut the signal off. The way we'll do that is we have GTPase activity. Yeah, so this will actually shut itself off by cleaving this, and now it's back to GTPase. So there's always intrinsic GTPase activity in these G proteins. They shouldn't be active all the time. They should activate for a while, and then they should shut themselves down. Then activate again, and then shut themselves down. Well, in these tumors, they get a mutation in the ability to shut itself off. They get these mutations in GTPase. Now, it's written here in words. The gene is called GNASH. GNASH1 gets mutated, and that interferes with the intrinsic ability to shut itself down. Okay, so I mutate the gene, the GS protein can't shut itself off. So now it's always on. That's constitutive. It's always on, and it's always bringing in the signal. It's always making cyclic AMP, and the cell is always going to grow. That's how it causes the cell to grow. So GS mutations for growth hormone producing and ACTH adenomas. All right, now, do adenomas run in families? You get them sporadically, just bad luck. You get a mutation, you get it. Couldn't it run in families? Absolutely. It's a small percentage, about 5% of pituitary adenomas are actually running in families. And there's a bunch of genes that can run in the family. You got MEN, this one, this one, this one. The only one that's really high yield and you should spend any time on is the MEN syndrome. Yeah, multiple endocrine neoplasia 1. It's got a mutation in the MEN1 gene. That makes sense. Multiple endocrine neoplasia syndrome has a mutation in the MEN1 gene. This is a tumor suppressor gene. So when you knock this one out, now you can get tumors running in your family. Multiple endocrine tumors running in your family. So we'll talk more about this towards the end of this chapter. This one's going to be very important because if there's a familial syndrome and you diagnose only one tumor and you send them home, well, they can get other tumors in other organs and you send them home. You can never just diagnose a tumor and adios. You diagnose a tumor and you got to be Dr. House. Say, is that associated with anything? Ooh, that's associated with it. MEN, so I gotta look for MEN. If you do that, you are Dr. House. Because any doctor can diagnose and say, adios, pay me, bye. But you gotta be a doctor who follows up. You gotta make sure there's no associations that you should be looking for and watching for. Again, it's a small percentage, but that's what makes you Dr. House when you know that you should always look for the familial things. And just for fun, this is a P27 checkpoint mutation. That's a different mutation. There's another one. This one is kind of interesting. This is an aryl hydrocarbon receptor interactive protein. This occurs when you in families who get growth hormone tumors very young. Very young. They get very young running in the family, and they have this AIP, this aryl hydrocarbon receptor interactive protein mutation. Again, I don't think I've ever heard it on the exam, but I just want to let you know that there are multiple mutations. What we're going to talk about is MEN, but there's other mutations for familial tumors as well. Now, if you see p53 mutations, well, that's never good. p53 makes it much more aggressive. So this is a tumor that may grow more rapidly and maybe become more invasive. So adenomas are supposed to be benign. So if it has p53, it can be more aggressive, be more infiltrative, harder to resect. That's never a good thing. Okay. All right, now, here's what an adenoma looks like. Let's start with normal again. Normal's got the reticulin framework, dividing the cells into these nice groups. And it's got different colors. It's got the blue ones, it's got pink ones, it's got different colors. Now, an adenoma is a benign tumor, but look what it looks like. It's all sheets. There's no grouping, nice grouping like you had before. So basically, it's just single cells, just sheets. They all look the same. Very monotonous, very monomorphism. It's all the same. It looks like the same cell has cloned itself. It's kind of like Agent Smith in The Matrix, right? He goes up to everybody, goes, now you're Agent Smith, now you're Agent Smith. They all look the same, all these cells. And notice they're all the same color. They're all pink. They're all pink. So we're missing the reticulin framework, that beautiful reticulin pattern. We're seeing monomorphic, and they're all the same color. So what kind of tumor is this going to be? What is it going to be making if it's all pink? What kind of tumor is this going to be? What's it going to be making? Making you apply your knowledge. Oh man, that's not fair. Yeah, it's GP. See, if you turn red, go see your GP. So it's either making growth hormone or prolactin. Very good, very good. All right, now the behavior, is it going to just slowly grow? Is it going to grow rapidly? Is it going to be infiltrative? We cannot always predict it by histology, because a lot of these tumors, they look the same whether they're very invasive or not. So one thing we want to look for is the borders on it. Does it have a nice capsule? Is it invasive? Invasive ones lack a capsule. They'll have local invasion. So the histology, the appearance of the cell, is not really going to help me much, right? But what will help me is the capsule. Does it have a capsule? Does it lack a capsule? Is the borders like well circumscribed, or is it invasive? Now, we call them atypical adenomas. Atypical, which may mean they're going to be more aggressive. When we see an increased mitotic activity, so we see a lot of mitoses, that's worrisome. If we see increased proliferation marker, Ki67, you see high Ki67, that's usually aggressive tumor. If you see nuclear P53 staining, that means the P3 has been mutated, so now it's accumulating in the nucleus. It's not working, it's damaged. So nuclear P53, that means a P3 mutation is present, and these are the ones that tend to have more aggressive behavior. So again, the ones that are atypical are the ones that are usually more aggressive. Look for mitosis, look for Ki67, because the actual appearance of the cell is not going to help me. Most tumors, if they look like normal, they have low grade. If they look ugly, they're high grade, and that helps us with how they're going to behave. But for endocrine tumors in general, hard to tell. Hard to tell what it's going to do based on the appearance of the cells. You got to look at, is it fading? What's the margins? What's the mitosis? Those are things you got to look for. All right, now here's a summary. I should probably put this at the end, but just a summary of all the different pituitary adenomas they can ask about. And here are the different cell types: corticotrope cells, somatotrope. Soma means body, trope means grow. Or grow your body, that's growth hormone. Lactotrope is breast, right? That's making prolactin. Oh, here's an interesting cell. It's actually a pituitary cell that makes both. Mammotosomatotrope cell. Well, mammy, that's your prolactin, that's lactation, and soma's body. So this is like a combo. This is kind of combo. And initially, we thought each cell only made one thing. And then we started noticing, we didn't realize it, but we started noticing a lot of the cells are making both. They're making both prolactin and growth hormone. So if you have a tumor of this cell, this is going to make both prolactin and growth hormone. It's going to make both. You'll have combined features of growth hormone and prolactin excess. Very interesting. Thyrotroph cells, they make TSH, and they'll give you, obviously, hyperthyroidism. Gonadotroph cells make FSH and LH, but they usually don't make much. They make a very little amount. So usually your gonads actually fail. You would think your gonads work extra. No, they just don't make a lot. They're very non-functional. So they cause more of a mass effect and usually destroy the pituitary rather than create a hyperstate. Interesting. Now, the highest yield are going to be the somatotrope, which gives you growth hormone. So if you're a child, you become a giant. If you're an adult, just some of the bones will get big, so you get acromegaly. Another one that's super high is prolactin. If it makes prolactin, a woman's going to get nipple discharge. She's also going to get osteoporosis, amenorrhea. Guys are going to get sexual dysfunction, infertility. So they really like these two. These are the two highest yield. And then a third runner-up would be Cushing's. Cushing's. So ACTH producing, you'll get high cortisol, and you get Cushing's. So these are the money. These are the three we're really going to focus on. All right, now let's get to them. Highest yield ones. Prolactinoma. So sexy for exam purposes. Another name for it is a lactotroph adenoma, an adenoma of lactotroph cells. Now, it's the most common type of adenoma, so that's always important. It accounts for 30% of all adenomas. Now, it usually is weakly acidophilic, so it's red. Remember, GP, so it's red. And sometimes it doesn't make much. If it doesn't make much, so it's a non-functional one, doesn't make much, you'll see cells that don't have much pigment. You call them chromophobe cells. So again, if it's making a lot of symptoms and a lot of prolactin, you'll see red cells. If it's non-functional, not making much, it'll be more chromophobe. And that's true for a lot of these tumors. They can either make a lot or they can make very little and be basically clinically undetectable until they get mass effect. Now, one interesting is it tends to have a lot of calcification. So when you see these on a CT, you're going to see a mass in the anteropituitary with lots of calcification. And that's different than the other ones. So calcified adenoma, we think more prolactin. It's not definitive, it's something to think of. Now, the amount of prolactin the patient is going to have in their blood is going to be proportional to the size of the tumor. The bigger the tumor, the more prolactin. Now, the reason the board loves this is the symptoms. If a woman is reproductive age, when she has prolactin, she's going to start getting a clear or milky nipple discharge bilaterally. So high prolactin, you get galacturia. Now question, are you going to notice that? Or is that going to take years to present? I look down, my shirt is wet. I think I'm going to notice that, right? You're going to notice that. So this is usually picked up early, so they're usually microadenomas. They're usually small because you get symptoms. galactorrhea, you're going to notice that. In addition, they can get what's called secondary amenorrhea. In other words, they stop cycling. They stop having periods. That you're going to notice, right? Every month you cycle, and if you stop cycling, all of a sudden, like, what's up? Infertility, that can be harder to detect because not everybody's trying to get pregnant all the time. Harder to tell. And osteoporosis is going to take a long time to manifest, and somebody young and healthy like you would take a while. But they will get osteoporosis accelerated. Now, the reason for these three things, and that's something the board's going to ask why. The reason is prolactin inhibits GnRH. Prolactin inhibits GnRH. So your gonadotropin releasing hormone is kind of inhibited by prolactin, and therefore your gonads aren't going to work. So this poor woman's ovary is going to be like, wee, 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 wee. No ovary, no estrogens. So that's the key. The ovary stops working, and you're missing the estrogens. So that's why you get osteoporosis, infertility, and you're not going to cycle. No estrogen, you're not going to get proliferative phase. You're not going to cycle. So very important to remember this association. That's how women are going to present. Now, what about guys? Can I get a nipple discharge? Do I have, no, dude, you have ducts. You don't have much lobules. You're not going to be able to get a nipple discharge. So in men, it's going to take a little bit longer to present. And also older women too. If she's postmenopausal, she's not going to have the sufficient material to make milk. So this can be a little bit more difficult to detect in men and older women. Older women also not cycling, so you're not going to see the amenorrhea, you're not going to see the nipple discharge. All right, now the hormone manifestations, they can be subtle. You will get infertility, but again, not everybody is trying to get pregnant. Not every guy is trying to get pregnant all the time, or is not trying to get somebody else pregnant, I should say. This I would notice right away. Loss of libido and impotence. I would notice this instantly. Loss of libido, what? Impotence, what? John, maybe he's single. Maybe he's on the internet all the time. Maybe he's not. Guys should notice this. Maybe he's preoccupied with Nintendo or something. But anyway, that's how it's going to present to that guy. It's going to present with loss of libido, impotence, and infertility. It can be kind of subtle. Now, in men and older women, since the manifestations aren't so prominent, these tumors can get very large. So, women, they're usually microadenomas, they're usually really small. For men and women, or that are older, you can have tumors that get very large. Now, for therapy, there's two ways we can deal with this tumor. We can do surgical resection. You go transsphenoidally through the sphenoid bone and resect it. Or you can use bromocriptine. Remember, bromocriptine is dopamine agonist. So that will stop the tumor from releasing its hormones. That's cool. And it can also shrink the tumor too. In fact, sometimes if they're going to do surgery, they'll give bromocriptine first because that will actually shrink the tumor and make it much more easy to resect. So again, two ways you can go about it. You just take bromocriptine to reduce symptoms and shrink the tumor, or you can do bromocriptine and do surgery and actually remove it. It really depends on the size of the tumor, are they a surgical candidate, and so forth. All right, feel good about this one? So let's repeat. Prolactinoma makes prolactin. Prolactin is going to give you a milky discharge. It's going to make you lactate, and it's going to inhibit gonadotropin release. So unfortunately, you're going to get all these features. Now, is there anything else that can give me hyperprolactinemia? Sure. Most common causes of pituitary adenoma. So when I see high prolactin nipple discharge, I always think about an adenoma. But of course, you get high prolactin if you're pregnant, right? If you're pregnant, it should be peaking near delivery because the baby's about to come out. You want the woman to be ready to lactate. So high prolactin in a pregnant woman, that's physiologic, that's good. Also physiologic is nipple stimulation. If you stimulate the nipple, it's like a suckling, like the baby's sucking on the nipple, that will certainly increase prolactin. And that's a good thing. That's physiologic. That's good. What else? We can have lactotroph hyperplasia. That's from the lack of a dopamine inhibition. So if the hypothalamus dysfunctions, doesn't work right, doesn't make enough dopamine, you get hyperplasia and high prolactin. Here's an important one for example. Dopamine antagonist. Anybody taking an anti-dopamine drug is going to have high prolactin. And if it's high enough, it can give you, in a woman, the nipple discharge. Very good. So these are the two that I really want you to remember. Pharmacology, and I want you to remember tumors or pathology. Okay, now the next tumor that's super, oh, I forgot, I gotta show you the microscope. I'm so excited to move on, but I gotta show a microscope. Oh, but this is the next one too. So this is the pituitary growth hormone adenoma. Growth hormone, second most tested, so prolactin and growth hormone, most tested. But they may use the other name for it. What's the other name for growth hormone? Somatotrophin. What? Somatotrophin. Soma is body, trophin is growing. So somatotrophin is another name for growth hormone. So the tumor cell is called somatotrope, somatotrope adenoma, somatotroph. These are the cells that make growth hormone. Now it's the second most common type of functioning pituitary adenoma. And there's two variants to it. As I mentioned for the previous one, it can make a lot of hormone or it can make very little. If it makes a lot, you're going to see lots of granules, lots of granules. So these cells are going to be very red because they're making a lot of hormone, very acidophilic. And on EM, here's what you're going to see. I probably should have shown this earlier. But anyway, same thing for the prolactinoma. You'll see lots of these secretory vesicles containing, in this case, growth hormone. And that's what makes it look so red. Now, if it's not very functional, it'll make very few granules, so very few granules, and therefore, under the microscope, you get how much color. It's going to be a chromophobe cell, and those are usually non-functional. Those are not making much. All right, now, when you grow, how fast are you going to notice that? You grow slowly over time. You're not going to notice it. So this is usually a slow onset of very subtle changes in your facial bones and your forehead, your chin. It's kind of hard to notice. It's very subtle. So these are almost always big by the time they're picked up. And that's one of the reasons they like them, because they'll give you symptoms and they'll get huge, huge. So they can often give you the bitemporal hemianopsia. I like this one. All right, now let's talk more about growth hormone. Growth hormone does not do all the growth. Growth hormone itself actually works on the liver, excretion, stimulates the liver to secrete insulin-like growth factor. That's what really causes the growth. Insulin-like growth factor, also known as somatometin C. They may use this older name for it. It's called the somatometin C. So insulin-like growth factor, also known as somatometin C, this is what really regulates most of the growth. Okay, so I know growth hormone, you think that does it all? No, it's insulin-like growth factor that actually does most of the growth. All right, now when they get this tumor, what age is the key for what symptoms you're going to get. So if they get it when they're young, in other words, prior to the closure of the growth plates are still open? Well, now your long bones get long and you become a giant. They call it pituitary gigantism. You become huge. Like Andre the Giant is an example. He was huge. Now, if you have the tumor after, when you're an adult and your growth plates are already fused, well, now the bones can't get long. But which bones can still grow? Well, the hands, the feet, and the facial bones. Those will grow. So we call it acro because that means extremity, hands and feet. Megaly means big. Acromegaly, your hands, feet, and face get big. They get big. So if the hands get big, the rings don't fit. If the shoes get big, the shoes don't fit. And of course, if your head gets big, the hat don't fit. Now, there's another disease that also gives thickening of the bones of the skull. We're going to talk about that in the bone section. It's called Paget's disease of bone. I'm just going to put it here because it can look a little bit similar. Paget's disease of bone often gets a very large forehead. Their head gets really big and the hat doesn't fit anymore. So two diseases where the hat don't fit no more. Paget's disease and growth hormone producing adenomas. So if the hat don't fit, pick Paget and acromegaly. If the hat don't fit, pick Paget and growth hormone producing adenomas. So it's just kind of silly, but it helps you remember. If the hat don't fit, think Paget and growth hormone. Now, do most people wear hats anymore? Not so much. So the vignette will say something like a baseball hat. They got to take off the baseball cap and they got to make it bigger. And they put it back on. Then a couple months later, they got to make it bigger again. Or motorcycle. If you're driving a motorcycle, you need a helmet. Well, should you need to get a new helmet? No. Once you're an adult, your head size should not change. The only reason to get a new helmet is because you like a new paint or a new safety feature. You shouldn't have to buy a new helmet because it don't fit when you're an adult. So that's a very important clue. Motorcycle guys, helmet don't fit no more. That's a problem. His head's growing big. But John, what if he becomes an orthopedic surgeon? Then he has a big head. No, no, that's a big ego. His head size doesn't actually change. His ego changes. When you become orthopod, you think you're like God's gift. I know. Crazy. Or neurosurgeon, you think they have big egos. Their head's not really bigger. All right, now let's talk about some other features aside from bone growth. What else can this insulin-like growth factor affect? Well, unfortunately, it can give you diabetes. So they tend to have high sugar, if not outright diabetes, because growth hormone actually counteracts the action of insulin. It messes up insulin. So that's going to lead to glucose intolerance, and eventually, if it gets high enough, you get diabetes. And that is something the board asks a lot. Everybody knows growth hormone, you're going to grow, you're going to be big, but you're going to have high sugar too. It's important. High sugar because it messes up insulin. It's also going to increase your blood pressure. You tend to have hypertension in half the cases. They tend to get very weak muscles, very generalized weak muscles, and they get arthritis because they're giants. You have to carry on all that weight. You're going to get a lot of arthritis. Do you remember Andre the Giant, the wrestler, Andre the Giant? Well, number one, he was wrestling, so that's a lot of wear and tear on your joints. And number two, he's a giant. So he had so much bad arthritis. If you ever read about him, every night after the wrestling match, he would go back in the locker room and drink like 6 bottles of Jack just to numb the pain from all the joint pain you have. So that's one of the problems of being a giant. Your joints were not designed to be a giant. Now, it can also get gonadal dysfunction because growth hormone-producing tumors often secrete prolactin. Remember the combo one? The combo cell? Yeah, if it's a tumor of the combo cell, it's going to make prolactin too. Prolactin messes up your gonadotropin-releasing hormone. Your gonads fail, and you get the problems with your gonads not working. Make sense? All right, now what about this? Well, the number one cause of death, and this has been a question, in fact, what killed Andre the Giant? Congestive heart failure. Because you're so big, your heart is working so hard to pump blood to a giant, eventually it's going to fail. It's going to fail. And then finally, do you think growth hormones may cause cells to grow and eventually become malignant? Yeah. So you're at higher risk of getting GI tumors like colon cancer. So you got a higher risk because things are being stimulated to grow. Yeah, it's not just your bones. Your organs are going to be big. Your blood pressure is going to be big. Your sugar is going to be big. Lots of things get big when you have a growth hormone producing tumor. Now, which one is not like the other? These are sisters, but one's is different. Okay, sister. She's huge. She's huge. I mean, look at how tall. So this is an example of a person who had a tumor as a child, so they became a giant. He grows slowly over time. And then they also didn't get discovered after the bones fused, so they also got acromegaly. Because if you look at a forehead, I mean, it's very square and very large. Rectangular, very rectangular, large. Her jaw is very squared, like a man, very square jaw. Very coarse facial features, that's acromegaly. The hands are going to be huge. Her feet, she won't be able to wear her sister's shoes, that's for sure. I mean, look at where her knee is compared to the other two. Wow, those long bones are long. She is very tall. So this is a pituitary giant with acromegaly. She has both. And that's very common to not to be noticed because kids are growing. They get the growth spurt. If one kid grows fast than the other kid, all the kids are different sizes, right? This kid is just much bigger than everybody else. And then they keep going. That's when you finally notice it. All right, now here's another important example. This is what's called acromegaly. She's not a giant. She got this later. So here's an old photograph of her. And then sure enough, when she gets this, what's going to get thicker? Her bones, her rings don't fit anymore. The shoes don't fit. She has to buy new shoes. And then the facial bones. Notice the way the forehead is kind of protruding here. It's kind of protruding. It's very rectangular, very broad, bumpy here, very bumped. Her nose is kind of bigger and bulbous now. Bigger and bulbous, that growth. Looks like the bones here grew. Looks like the lips are close to bones have grown here. Look at the jaw is more kind of like squared off. It's more squared off. So here's how this often presents. Since you grow slowly, you're not going to notice the change, the subtle change from one day to the next. If you see her every day, you're not going to notice it. You're not going to notice it for years. Then when you look at old pictures, you're like, man, I've really changed. Or somebody sees you that hasn't seen you in a long time, they're like, whoa, you look a lot different than you used to. That's when you'll notice it, because every day you don't notice small, subtle changes until you look back. You look at old pictures, or somebody comes to visit you and notices you're different. So one way this is going to present, since these tumors get very large by the time you find them, they often have bitemporal hemianopsia. So what happens is she gets into a car accident. What's the police officer going to say? Sir, can I see your driver's license and registration, please? He looks at the driver license picture and says, sir, this is a woman. You give me a woman's license. No, officer, it's me. Oh. You don't notice until you look at the old picture and the license. And you guys have no idea what I'm talking about. But it's one of the worst days of your life. The day you have to go to the DMV and get a new picture on your license. Every 10 years, they want me to do a new picture. I hate it. Because it's like I look at the old picture and I'm like, that's 10 years ago when I was young. And now the new me is not quite as good as the old me. Can I keep this picture, please? So you look at that old picture, you realize how young you were. See, you're young, you don't understand. But wait a couple of decades, and you start saying, can I keep the picture when I was 21? I'll keep it forever. Then I go to the bar, and they say, can I see your ID? It's like, dude, this is a kid, this ain't you. No, it's me when I was 21. I would keep that picture forever. In my mind, I'm still 21. I'll always be 21. Crazy. My mom said, pick an age you like and stick with it. All right, now for fun, take a look at Andre the Giant. He was not only a giant, but he also had acromegaly too. Look at the forehead. See the way it's squared off? See how big it is? Compared to Hulk Hogan. Now Hulk's a big guy too, but he's like a monster compared. Look at the nose. His nose is huge. Look at the jaw. Huge. And of course he had a heart flare. I mean, this guy is a monster. He was also the Princess Bride, ladies. He was the giant in the Princess Bride. Look at how big he is. Andre the Giant. Ezek. Now, when he actually put his hand over her face. You couldn't see her face. I mean, his hand was bigger than her face. Wow. I mean, poor guy. He had a lot of arthritis because he was a wrestler, and he wound up with he also had diabetes, and he wound up with heart failure. That's what killed him. Another example of this would be you're probably too young to know this. James Bond, the Roger Moore. This is way back in the day, way before the new guy. But anyway, way back in the day, he used to fight this character called Jaws. He had these metal teeth. They called him Jaws. Look at how big he is. He's like, his hand is like squishing James Bond's face. You can't even see James Bond anymore. He was huge. And then he electrified his teeth. That's the way he got rid of him. Electrified his teeth. His name was Jaws. Now, he was an actor, and he was also in a more recent movie. Do you remember Happy Gilmore? That's your more your generation. Happy Gilmore. Adam Sandler was a hockey player who decided to go and play golf instead. Well, anyway, he was having a rivalry with this other guy, and this other guy hit the ball onto his foot. And he was like, rrr, and he had to hit the ball off his foot, and at the end of the movie, he's chasing him. I'll get you, Shooter McGavin. I'll get you. And I was like, they did it in slow motion. Rrr. I'm like, why are they doing that? It looks so fake. And then I realized, he's got arthritis. All these patients with the Giants, they're going to get arthritis when they get older. He couldn't run after him. So they basically sat him on like a wheelchair or something, and they said, we're just going to shoot you from here up and go like this like you're running. And it looks so fake in the movie. You go back and watch Happy Gilmore, you say, oh, that's why it looks so fake. Because he couldn't run. These guys get arthritis from being a giant. They get high sugar too. You had high sugar, you wind up with heart problems. All right, now another example is Tony Robbins. If you saw the movie Shao How, Tony Robbins, motivational guy, is in the elevator with him, he gets stuck, and he actually puts his hand on his face and it covers his face up. Classic example of acromegaly. Yeah, it's a giant, pituitary giant with acromegaly. Huge. And then here's the last example. Do you remember the story from the Bible about David and Goliath? Goliath was a pituitary giant with acromegaly. He had a pituitary tumor. That explains it. That's why he was so huge. That's why they put him in the front. Because when you saw him coming, you're like, if everybody else looks like that, we're screwed. They got a giant. So they put him in the front. And how did David beat him? Well, with a sling. Remember, a sling comes around from the side? The giant never saw it coming because he has a bi-temple. He never saw it. So when it came around from the side and hit him in the head, he never saw it coming. Hit him in the head. Now remember, when it hit him in the head, that tumor bled into itself. Apoplexy. From the head trauma, it bled into itself. So basically, it rapidly enlarged, and the giant fell down, and he was dead. That was it. It could have happened. Explanations of biblical stories. Are you not entertained? It could have happened. It could have happened. Wow. All right, next time you're at a medical cocktail party, bust out that one, and they'll be impressed by your knowledge. It really could have happened. Wow. Beat him with the sling, because it's coming in from the side. The giant couldn't see it coming. All right. Now, let's talk about how we diagnose these growth hormone tumors. Well, you're growing big. Clinically, you look like it. But how do I confirm it? Well, we're going to screen by measuring insulin-like 1 growth factor levels. Now, tell me, why don't we measure growth factor? Why don't we measure growth factor levels? The tumor's making growth hormone. Why do we measure this? Do you know why? That's Mr. Gilmore's jacket. That's right. Yeah, because growth hormone levels fluctuate throughout the day. They fluctuate. Like you get a big spurt at like 5 in the morning. It fluctuates throughout the day. So what do you measure all day long? Insulin growth factor is more steady state. So that's how we screen, by looking for elevated levels of insulin-like growth factor. And that's how growth factor works anyway, right? Growth hormone, it works through insulin-like growth factor. So we're going to measure this anyway. Now, to confirm the diagnosis, we'll actually try to suppress growth hormone. We'll try to suppress it, because that we can measure. If it's really low all the time, we can measure that, right? So here's what we'll give you. We'll give you oral glucose. Oral glucose. Because oral glucose should rapidly suppress growth hormone. So if I give you oral glucose, you're normal, growth hormone should suppress to less than 1 microgram per liter within 1 to 2 hours of giving it. So if I give you glucose, it should drop to very low levels. What happens when you have a tumor? Is a tumor going to listen to the high sugar? The tumor's like, hell no, I'm just going to keep making it. So growth hormone will not suppress. Okay, so again, when tumors are hyperfunctional, what do we try to do? We try to suppress them. So we do a growth hormone suppression test to confirm this diagnosis. So high levels of the insulin growth factor, good screen. Confirm it by trying to suppress. When you can't suppress, that's a tumor, because normal pituitary should suppress with sugar. All right, now to find the tumor, we do MRI. MRI is a good imaging technique to look for anatomy, and it can show us the sella petursica, it can show us the pituitary and any masses there within. Now, what I want you to notice, and this is a good rule, for endocrine diseases, you never start with radiology. Never start with radiology. Hey, I think there's a pheo. No, you don't do a scan of the adrenal gland, because sometimes you'll see nodules or little benign things in these organs anyway. So you'll be cutting out a lot of things that mean nothing. So again, we never start with imaging for endocrine organs, because endocrine organs can be bumpy and they can be lobulated. It can look like a mass. So never start with imaging. We only do imaging once we have biochemical indication that there's a tumor. Okay, so it's basically labs first, radiology second, never first. Okay, and they always do that on the exam. They always say, which of the following tests should be done first? Don't do imaging for endocrine problems. Always start with biochemistry. Look in the blood, look in the blood. All right, now for treatment, again, we have 2 ways to treat it. We can resect it. So initially, most people are going to do transsphenoidal resection. So that's how you get to it. Or we can do suppression by using drugs. So adjuvant. Okay, now in this case, we almost always do surgery first. And if that doesn't work, we use these adjuvant treatment drugs. Now for the boards, I know they're going to ask you about the treatment here, these drugs. So if the surgery fails, what drugs can I use to inhibit it? Well, we can use dopamine agonists like bromocriptine, cabergoline. These are the drugs we can use because they work like dopamine. They're dopamine agonists. Now, wait a second. Didn't dopamine inhibit prolactin? Did it inhibit Yes. But remember, a lot of these tumors make both. They make prolactin and growth hormone. So that's why this will work in the majority of cases, because they make both. So this will inhibit the tumor, make it shrink, just like it did the prolactinoma. Very cool. Now, better is somatostatin analogs, because we know somatostatin is inhibitory for growth hormone, right? So we'll give octreotide. That would be great. Or lanreotide, the Tide drugs, OTide drugs. So octreotide is a great example of a somatostatin analog, and would be great for inhibiting these tumors. Now, the newest, sexiest drug. Let's actually block the growth hormone receptor. So instead of stopping the growth hormone, these are going to try to stop the growth hormone from being made. Let's just block the receptor for it. That's supposed to the growth hormone won't have an effect. So growth hormone receptor antagonist, and I can barely say its name, pegvisomant. Who's making these names? Pegvisomant. Couldn't you call it growth factor receptor mAb? Well, it's not a mAb. What it really is you took growth hormone from humans and you modify it. You modify it so it'll bind to the receptor, but it won't block it. That's all we did. We just took an analog of human growth hormone and we structurally changed it to block the receptor. So we take growth hormone, modify it so it just gets stuck in there, and therefore the high levels of growth hormone won't have an effect. That way the body will stop growing. Make sense? So again, the best treatment for this is usually transphenol resection. If it doesn't work, we can add these other drugs. Now, do you remember what a transphenol resection is? How do you do that? Well, I just want you to know this because it was a board question they asked that student missed. So I want to make sure you don't miss it. So I'm just going to show you this picture. Let me erase all this stuff so you can actually see it. Then we'll take a break. There she goes. All right, transphenol. Notice how we go in. We go in through the nose, or sometimes under the lip. Sometimes they go under the lip too. But usually going through the nose. When we go in through the nose, we'll go through the sphenoid sinus, right through the bone, into where the pituitary is. This is the sella caturcica right here. Notice how it's really big because they have this yellow tumor on this blue pituitary gland. So it really enlarged the sella caturcica, but we can really get in there really good without entering the brain by just going through the sphenoid bone, transsphenoidally. Now, I want you to remember this because they asked them an exam and student missed it. Everybody knows the pituitary sits inside the sella caturcica, right? It's sitting in the sella caturcica. That's where it sits, sella caturcica. Well, student was asked, what bone does the pituitary sit in? And he's like, sella caturcica. Yeah, but what is that? It's in what bone? What is the sella caturcica? That space, that sella. What? And he didn't know. I said, dude, remember you do transsphenoidal resection. This is the sphenoid bone. It's the sphenoid bone. You're going through the sphenoid bone to get to the tumor. He's like, oh, I didn't realize that. So transsphenoidal resection to go through the sphenoid bone to get to the sella caturcica to remove that tumor. By the way, we can also remove craniopharyngiomas. Remember the Rathke's pouch is right above here. So we can do the same thing, go through this transsphenoidal and resect craniopharyngiomas as well. Because I don't really want to open up the brain. If I have to, I can avoid it because I have to open the brain, go underneath it. I have to lift up and go, oh man, to get to the base of the brain, it's hard to get to the base of the brain. So doing transsphenoidal, even though it looks nasty, you're going into the nose or under the lip through it, looks pretty nasty, but it's a heck of a lot better than open up your skull. Make sense? All right, let's take a little dessert break. We'll come back and we'll far so good. Going through the pituitary tumors, that's the first organ we're going to handle. Then we'll do the thyroid next. So we got to finish up some of these pituitary tumors. Now we did prolactin producing, we've done growth hormone producing. Now we're going to do ACTH producing adenoma. Now obviously this works on the adrenal gland, gets the adrenal fired up, and you make a lot of cortisol. Now a synonym for this would be a corticotroph cell adenoma. And they tend to be small microadenomas because they're going to give you symptoms relatively quickly. And you got to come in and get diagnosed. Now, ACTH producing adenomas, they tend to be PAS positive because they have sugar. It's glycosylation of the ACH precursor protein. ACTH comes from POMC. You remember this from biochemistry. This was a big precursor molecule that not only makes ACTH, but also you can derive from this MS, melanocyte stimulating hormone, and also endorphins as well. They all come from this big old molecule. All right, so we're going to talk about specifically breaks down to ACTH, which reminds me, ACTH can be cleaved into melanocyte stimulating hormone. So if I ever have high levels of ACTH, you are going to get hyperpigmentation, particularly along the creases. You will get bronzing, you'll get darkening of your skin, especially in the creases, because ACTH has melanocyte stimulating properties. It's part of that molecule. All right, now as just like the other tumors we've talked about, there are two variants. There's the densely granulated, that's the one that's going to be very blue, and then we make a lot of hormone. Then we have the sparsely granulated, which is chromophobic, and that will have very few production of ACTH. That will be more non-function. All right, now the problem with this tumor is when you make ACTH, you make cortisol. So you get hypercortisolism. This is one of the causes of Cushing's. All right, we'll talk about pituitary tumors, make Cushing syndrome. We have adrenal tumors. We have ectopic ACTH. So there's going to be several categories of Cushing's, but there's only one that comes from the pituitary, and Dr. Cushing was the one who described it. So it's the only time we're going to use the term Cushing's disease is when there's a pituitary adenoma making ACTH. Otherwise, you call it Cushing syndrome. So we always call it Cushing syndrome. If it's due to pituitary tumor, then you change the name to Cushing's disease, because he was the surgeon who discovered that pituitary adenomas can cause ACTH and Cushing's. Now again, it's because of a tumor making ACTH in high levels. Now, if the tumor is making too much, we're going to try to suppress it. We're trying to suppress it. So we're going to do a dexamethasone suppression test. And it will suppress with high doses only. Low dose, the tumor won't respond, but high dose, it will respond. So that's a very important test to determine the pituitary is the one responsible. Then what will you do next? Well, you'll get an MRI of the sella caturcica to see the tumor. But again, first we start with biochemistry. We find cortisol is high, that's hypercortisolism. And we do the dexamethasone test. If it's suppressed with high dose, that's a pituitary tumor. Then we'll check MRI. So it's always biochemistry first, radiology second. Now, very rare, but it's something that the boards would like to ask about because it's interesting. It's kind of rare. We don't do this much anymore, but it's called Nelson syndrome. Nelson syndrome. This is when you suddenly get a rapidly growing, very destructive adenoma after you take out both adrenals. Now again, do we like taking out both adrenal glands? No, I'd like to save one. We don't want to take it all out. But in the old days, they used to treat Cushing's disease by taking out both adrenal glands. So this is not common now, but I guess if somebody, I don't know, got gunshots and both adrenals were removed, or maybe they had a bilateral pheochromocytoma, had to take out both adrenals. So it's kind of rare, but if both adrenals were removed, well, what would happen is the tumor, if you have the tumor, it would grow very rapidly. Why? Because without adrenals, there's no cortisol. Cortisol is supposed to give negative feedback on the pituitary. So when we lose the cortisol, we lose inhibition on the pituitary adenoma. So the tumor starts growing like crazy. That's very important. So the adrenal is supposed to give negative feedback by cortisol. Without that negative feedback to inhibit the tumor will grow rapidly. rapidly. Okay? Now, question, as the tumor now grows, you're going to make lots of ACTH, but you won't get hypercortisolism anymore because the adrenals are gone. Duh. So the tumor makes lots of ACTH like crazy, but you're not going to get any Cushing's because the adrenals are gone. But what will you get? You'll get hyperpigmentation. Hyperpigmentation because of the stimulating effect of ACTH on melanocytes. That's like similar to melanocyte stimulating hormone. All right, so there's two ways they're going to present. After the surgery, they're going to get hyperpigmentation because of ACTH, and they're going to get mass effects because this tumor is going to rapidly grow and push on everything. So headache, papilledema, increased intracranial pressure, maybe the optic chiasm being affected. That's how it's going to present, rapidly growing after the adrenalectomy. Okay, so again, it used to be common for people who had treatment for Cushing's, but not so much anymore. All right, now, the ones the board like are the pituitary tumors that make stuff. They make prolactin, you get nipple T-drugs. They make growth hormone, you grow. They make ACH, you get Cushing's. They kind of like those because they give you cool things to talk about. But about 25% of all pituitary adenomas are what's called non-functioning. Non-functioning. Now, non-functioning falls into two categories. Non-functioning means it's making stuff, but not enough to be detected. It's clinically silent. So it makes stuff, but just not enough. Or it could really not make anything. That's called hormone negative null cell. So it can either make zero, or it can make a little, and you just can't detect it clinically. So those are what we mean by non-functioning. They're not giving us those classic symptoms that we would expect to see. Now, if it is making some hormone, we should be able to detect that by doing immunostaining. So it doesn't produce enough hormones to cause any clinical features, but we can determine where the tumor is this tumor of by doing staining. So we can stain for all the different molecules like prolactin, growth hormone, ACTH, and we can find out what it is. Now, when we do stain, we find out most of these non-functional ones, are gonadotroph adenomas. So that's the most common type of tumor that will be non-functional. It just doesn't seem to make enough to give any symptoms. So how are these going to present? Since they don't give us symptoms, they're going to present as a mass effect. Mass effect. So you can get the bitemporal hemianopsy, you can crush the rest of the pituitary and get hypopituitism because of pressure atrophy. Or sometimes they just get so big that they just eventually bleed. They bleed into themselves and they basically infarct. Pituitary apoplexy, this is often an emergency because the swelling from the bleeding can actually herniate your brain. Not cool. So again, these are called non-functional adenomas, about 25% of all tumors. They're clinically silent, but when you find them, you can see that a lot of them will make some gonadotroph-releasing hormone. All right, now the next category we'll want to talk about is the opposite. We did hyper states, now we're going to do hypo states, when the pituitary is not working. Now, like most of our glands, we have a lot of reserve. So this only occurs when you lose 75% or more of the anterior pituitary. So you got to lose a lot of the gland to lose the function. There's a lot of reserve. Now, in children, the most common cause is a craniopharyngioma. That was the tumor of Rathke's pouch. So here's my pituitary sitting in the sella caturcica. Rathke's pouch is right here. It's a little remnant of epithelium. Well, if it becomes a tumor, we call it a craniopharyngioma. In fact, it's one of the most common tumors. It's most common in children. And it's certainly the most common tumor to grow downwards and crush the pituitary. So now you're going to get pan-hypopituitism. The anterior pituitary is just not going to work. It's been destroyed. Now, in adults, the most common is a non-functional pituitary adenoma. We just saw an adenoma of the pituitary that just doesn't make anything. It just crushes the rest of the gland. Now, craniopharyngioma is very testable. And then there's another one that's very testable, Sheehan's, which Justin asked about already. Sheehan syndrome. Very interesting question on the vignette. They're going to say a woman is pregnant, she goes in for delivery, and she has a tremendous amount of hemorrhage. Now, wait a second. All deliveries have hemorrhage. They all do. She has to have a lot of hemorrhage. So much hemorrhage that she gets hypotensive after the delivery. So again, all women have hemorrhage. It has to be severe hemorrhage where she gets hypotension. If she gets hypotension, now you'll have infarction of the anterior pituitary. So we call this postpartum pituitary necrosis because there's just not enough perfusion. And here's the reason why. Here's the normal pituitary. Nice old gland, right? It's got a nice blood supply, nice blood supply. Now there's also posterior, I'm not going to draw it, but posterior has its own blood supply, has a different blood supply for posterior. I'm just talking anterior. Now when you're pregnant, the anterior has to do twice as much work. It's going to do baby too. So now it's going to double in size. And again, I'm only talking anterior now. It doubles in size. But the blood vessels don't double much. They don't change much. So here's the vasculature. It really didn't change. So I've got twice as big of a gland with about the same blood supply. So all pregnant women, their pituitary is like borderline ischemic. It's okay, but it's borderline ischemic. So as long as you don't get hypotensive, you're fine. But if you get severe hypotension, this anterior pituitary will infarct. That's called Sheehan's postpartum necrosis of the pituitary. Yeah, now this is very important. How will I know to pick this? Well, number one, they're going to say there's hemorrhage at delivery and the patient gets hypotensive. But then they're going to say, well, you tell me what hormones are missing now. Let's see. If the anterior is gone, you're missing prolactin, you're missing growth hormone, you're missing TSH, you're missing ACTH, you're missing LH and FSH. Wow, so a lot of stuff is going to be missing here. Yep, anterior does a lot of stuff. That's why it's so big. And none of these things are going to be made anymore. So what is the first symptom you're going to see? Well, after delivery, the mom wants to breastfeed, and she won't be able to. She'll cry. The baby's latching on. The baby starts crying because he's sucking and sucking and ain't getting nothing. Because without prolactin, the woman can't lactate. That's your first clue. First clue, failure of lactation because of the lack of prolactin. Make sense? Yeah. Now, of course, she's not going to grow either, but you won't notice that for a while. The thyroid, she's going to get hypothyroidism. You'll notice that relatively quickly. ACTH, trouble with stress, trouble with sugar. You bet, you'll notice that pretty quickly. Now, LH and FSH, or ovary fails. Well, after you deliver, you don't cycle right away anyway. So you're not going to notice that for several months. The cycles never start again because your ovary basically failed. So this is going to take time. This one you'll know relatively quickly. This takes forever to notice you're not growing. And of course, prolactin. So that's the earliest clue for this disorder. Now, problem is, you're going to have to replace all this for the rest of her life. Now, luckily, if there's some cells that are still there, they may be able to regenerate. But in general, you're going to have to replace this stuff. So this is not good. Sheehan's postpartum pituitary necrosis because of severe hemorrhage at the time of delivery. Make sense? That's why you need that octreotide. Give that manual massage of the uterus to try to stop the bleeding, and octreotide to try to stop the postpartum hemorrhage as well. Otherwise, you'll be at risk for Sheehan's. So great integration, Justin. Justin's the rock star. Rock star. You guys are good. Very good. All right. What else can cause the pituitary not to work? Well, anything in the area that can push on it. So how about granulomas? Maybe sarcoid granulomas? How about TB granulomas? How about trauma? Trauma, if you have trauma. How about, of course, surgery? The surgeon actually knocks off the artery going to the pituitary. How about metastatic tumors? Sure, they can spread there. And of course, this is important, hypothalamic disorders. This is the master control of your master gland, your pituitary, hypothalamus. If the hypothalamus doesn't work, then all of the pituitary, not just the anterior, remember these are mostly anterior problems, you're going to get hypopituitism for anterior, and the posterior ain't going to work either. You're going to get diabetes insipidus. So again, that's the secret for looking at hypothalamic disorders. Both anterior and posterior are affected together. Now let me change it. What if I only damage the stalk? If I only damage the stalk, Well, remember, if you damage the stalk, it's only the posterior that's affected. You'll only get diabetes insipidus. So I want you to get this in your brain. If it's anterior, you're going to get panhypopituitism. Everything is low, right? By itself. If it's the hypothalamus, they're both low. If it's the stalk, it's just posterior that's affected. And again, there's no disease of oxytocin, so you're going to have diabetes insipidus, ADH deficiency. Okay, make sense? Get that in your brain. Anterior is most of the hormones. Posterior is just diabetes insipidus, and of course, if they get pregnant, they have trouble with getting it, with inducing labor, the oxytocin. And then, of course, we got both. Both are going to be the hypothalamus. Do an MRI, look at the hypothalamus for a lesion. All right, now the clinical features of hypopituitism really depends on which hormone runs out, which one is affected. Usually it's all of them. So growth hormone is going to give you dwarfism. You won't grow if you're young. TSH, you're going to get hypothyroidism. ACTH, you'll get hypoadrenalism, adrenal fails. Prolactin, of course, lactation. And we talked about the gonads failing. You don't have estrogen, so you get amenorrhea, infertility, libido, impotence, osteoporosis. Without estrogen, you get bones that liquefy. So these are the classic features you all look for. And again, they usually, most of the time, they're all present together. All right, now let's talk about posterior pituitary dysfunction. This is fun. As I mentioned, no diseases of oxytocin. Yes. So all we got to focus on is ADH. ADH. We have one where there's too much ADH. That's the syndrome of inappropriate ADH secretion. And we have one that ADH is low. They're kind of opposite disorders. So ADH is low. We call this diabetes insipidus. Diabetes insipidus. Now I gotta ask you, what does ADH do? Do you know what it's supposed to do? Well, I got a crazy mnemonic. ADH. Adds water to your body. Adds water to your body. Adds water. It adds H2O. It adds H2O. It adds water to your body. That's the job of antidiuretic hormone. It won't let you diurese. It won't let you pee it out. You gotta hold on to free water. Yeah, it holds on to free water. It doesn't allow them to go out through the pores. So therefore you hold on to free water and your body kind of swells up over time. So you're holding on. So that's how I remember. ADH, the job is to add water. Well, guess what? If you have ADH deficiency, you're peeing out that water. You're having polyuria. So that's one of the reasons it looks like diabetes. They're peeing out a tremendous volume of urine, just like you do in diabetes. Diabetes gets osmotic diuresis. They're going to get diuresis very similar, very similar. Now, why do they call it insipidus? Do you know why? Do you know why they call it insipidus? No taste. In the old days, they used to smell the urine and taste the urine. They'd smell it. If it smelled like maple syrup, they'd say, oh, maple syrup urine disease. They would taste it. If it tastes sweet, you make a lot of urine, and it tastes sweet, you got diabetes. Then they had a patient with a lot of urine. Oh, it's got to be diabetes. Let's taste it. No taste. It's insipid. So they call it diabetes insipidus. Aren't you glad you're practicing today where we do dipsticks and we do urinalysis instead of tasting it? Crazy, huh? But that's how it got its name, diabetes. It's like diabetes because they're going to have polyuria, and they're going to drink too. They're going to drink a lot to replace it. So they're going to have drinking a lot and peeing a lot, just like diabetes. And it had no flavor, had no taste. So diabetes insipidus, crazy. Now there's actually two forms. Most of the time they're going to be asking about the central form. So that's what I'm going to spend all my time on. But I do want to mention there's a nephrogenic diabetes insipidus too. So let me just start with central. Central is an ADH deficiency, usually because you damage the stalk. It's usually a problem with the stalk. Boom, you damage the stalk, now ADH can't come down to the posterior pituitary. So a good example would be head trauma, where you damage the stalk. A tumor pushing on the stalk. Do you remember Langerhans cell histiocytosis X? Well, there was a triad, Hand-Schüller-Christian disease, where they had the tumor in the skull bones. It often pushed on the pituitary stalk, you get diabetes insipidus, and it pushed on the eye. So one eye was like bulging out. They call that exophthalmos or proptosis, just one eye. That's classic Hand-Schüller-Christian. And that's histiocytosis X. That's the old name. The new name is Langerhans cell histiocytosis. This is the one that had the perfect granules. Remember the perfect granules? You're still on your head at Wimbledon. Rafael Nadal. He's one ace away from winning Wimbledon. CD1A, one ace away. If only he can get his serve over 100. Serve over 100 and swimmer composite. So just remember that one. I really like that one. So histiocytosis X, giving you diabetes insipidus. What else? Inflammatory disorders, surgery where you cut the stalk by accident. Anytime you damage the pituitary stalk, you can get diabetes insipidus. Now, there's another form called nephrogenic. That means you have ADH, but the kidney doesn't respond to it. So the renal tubular cells become unresponsive to the ADH. So it's kind of like a deficiency because you have the hormone, but it won't work. It doesn't work. The kidney doesn't respond. So again, you're going to pee a lot of free water. You lose free water, a tremendous amount of volume. Now, what's going to make the kidney become insensitive? Taking lithium. Circle it, star it, tattoo it on your ankle. Lithium and nephrogenic diabetes insipidus, that's a famous pharmacology question. Now, another drug that can do it, what used to be an antibiotic we used to use, it's like tetracycline, but it's demeclocycline. We used to use it as an antibiotic, but the problem is the patients were getting diabetes insipidus. So it was treating the bacterial infection, but the patient was starting to pee like crazy. So we said, we're not going to use it anymore. It's an antibiotic, but we're not going to use it anymore. So we don't really use that much, but they could ask it on the exam. So lithium and demeclocycline are classic. Now, what else can make the kidney insensitive? Well, how about some injury to it? So maybe pyelonephritis, the inflammation, maybe some amyloid protein deposit in there, maybe some sickle cells getting stuck because of ischemia. Yeah, so anything that damages the kidney could potentially cause a nephrogenic diabetes insipidus where the kidney just stops responding to the ADH that you have. Okay, so that's the difference between these. This is a true deficiency, central diabetes, and then nephrogenic is you're not responding to the ADH. Now, in either case, look at the clinical. You can't absorb free water back into your body from your urine, so you're going to lose a tremendous amount. Makes sense. Antidiuretic hormone is supposed to stop diuresis. You can't have that hormone, you're going to diurese. You're going to lose a lot of free water. So the urine is going to be very voluminous. It's going to be very dilute. So large quantity of very dilute, because it's mostly free water, not much solutes. So you're going to get polyuria, just like in diabetes. Large volumes of dilute urine. If you measure the specific gravity, well, there's not much solute, so it's very low. Now, what is your serum sodium? Well, if you peed out all your water, you're dehydrated. You and your body are dehydrated. You didn't add water to your body. So you're dehydrated like crazy. So the sodium level is going to appear really high, because you don't have water. So it's really, really high. What about osmolarity? Well, you're very concentrated. So it's going to be high as well. So high sodium, high osmolarity. What about the urine? The urine's got low sodium and low osmolarity because you're not getting anything out, just water. Now, this hypernatremia does cause problems. It affects myelin. So you get CNS confusion, lethargy, coma, and seizures. No bueno. Don't like this. I don't like hypernatremia. I don't like hypo either. I like nice, normal levels. So not good to affect your brain. Now, here's the good news. As long as you can drink, you're going to be okay. Because when you pee out all this water, your brain will sense it and you'll get thirsty. So you're going to drink like crazy to make up for that. You're going to make up for that. So usually people can drink enough water to prevent any CNS problems. So the rule is, as long as you can drink, you're not going to have any problems. You're just going to be peeing a lot and drinking a lot. Peeing a lot and drinking a lot. So when are they going to come in? Because people just adapt. They're just thirsty, they keep drinking. They're going to come in when they can't drink anymore. So in other words, they're unconscious, they got passed out. They're hospitalized and they're bedridden. They can't get to the water fountain. What if they go on a hike? They're in the woods, they have nothing to drink. So that's when they're going to have problems. So in a hospitalized patient, it's usually somebody who's unconscious, right? They're unconscious, so they can't drink. So they're going to get dehydrated, and they're going to start getting CNS problems. So that's when they're going to present, when they can't drink. Now let's talk about let's talk about the diagnosis here. Okay, for diagnosis, the best initial test is to look at the urine. So we'll start with the urine first. You're peeing a lot, so let's say, give me a urine, let me see it. In the urine, you're going to measure the sodium level. What's it going to be if it's mostly free water? It's going to be really low. Low urine sodium, low osmolality, because it's all water. Now, normally your kidney can vary the concentrating ability from 50, which is very, very dilute, to 1400, which is very, very concentrated. That is the spectrum of the kidney's ability to vary the concentration. So this is the least concentrated you can ever make. I mean, you're just peeing out water, 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 water. There's nothing to stop it. Now, the most accurate gold standard test is deprive them of water. Because they want to drink. Tell them, nope, stop drinking for a little bit. Stop drinking. If you stop drinking, well, what if I told you to stop drinking? If I don't let you drink, what's your kidney going to do when you're not drinking? Well, it's going to try to hold on to water for you. It's going to concentrate. So normally, if I deprive somebody of water, you're going to see a low volume production of very concentrated urine. That's normal. It's like overnight. When you're sleeping, well, you're not drinking anything for 8 hours. So when you wake up in the morning, you have urine that's very concentrated because you didn't make much urine, but for 8 hours, that's quite a bit actually, over 8 hours. But it's a low volume produced over a long period of time. It'll be very concentrated. Now, in diabetes insipidus, tell them don't drink, kidney just keeps, there's nothing to stop it. High volume of very dilute urine, that is abnormal. So that's a good way to confirm this diagnosis. Deprive them of water and they still pee water out. They're going to get dehydrated very quickly. Now, here's another question. So now I got the diagnosis of diabetes insipidus. Is it central, which is most common, or is it nephrogenic? How would I distinguish between the two? Remember, this is an ADH deficiency. This is I have ADH, but it's not responding. Well, let's give more ADH. Let's give them ADH because this one's deficient, right? So if I give central ADH, what's going to happen? The kidney's going to work. The kidney's going to say, okay, antidiuretic, I will now hold on to water, so I'll pee out very little, and it'll start getting more concentrated. It works because the kidney's fine. Now, if it's the nephrogenic form, the kidney's not responding. So you can give all the ADH in the world, and it's not going to change at all. It's still dilute. It's still dilute. That should make sense, right? So if ADH is deficient, give ADH, give vasopressin, ADH, and sure enough, the kidney should work. Right? If you're missing ADH, you give ADH, ADH should work. All right, now treatment. For the central form, the number one is drink. Drink as much water as you need. Just keep drinking. As long as they drink, they'll replace what they pee out. Now, what if they can't drink? They're hospitalized, they're comatose, they're intubated. All right, well, then you're going to have to give them desmopressin, which is ADH. ADH analog. Another name for desmopressin is vasopressin or DDAVP. Now, let's think for a second. What else did we use desmopressin, DDAVP, vasopressin to squirt up the nose for? Do you remember what we used that for a long time in the way, way back machine? Yeah, we use it for von Willebrand's, and it also, not what else goes with V8, good, V8. You can use it for mild hemophilia A, big time, comes through. Justin and big time, tag team, excellent. You guys rock. So very important, desmopressin, we know the uses for it. Now for the nephrogenic, that's usually due to a drug. So stop the drug, stop the lithium, and should get better. Now, if that doesn't work, or if it's not due to drugs, then you can add hydrochlorothiazine and or NSAIDs. Exactly how this works, I have no idea. It must be a loop, works on the tubules or something. I have no idea how it works. You gotta ask the farm guys. But I know that's the treatment. So stop the drug. If stopping the drug doesn't work, or if they're not on a drug, hydrochlorothiazine. Does anybody know how it works? You guys did farm. Is your farm class over yet? Is farm done? Or are you still doing farm? What are you up to in farm if you're still doing farm? Oh, it's done. So you should know all this stuff. You just did all this stuff. You should be fresh. I'm a pathologist. I don't do drugs. All my patients are dead. It makes the proximal tube. Oh, okay. I believe you. I believe you. Very good. Very good. All right, now let's do the opposite. The opposite is too much ADH. Too much ADH, right? We'll call this the syndrome of inappropriate ADH secretion. I have too much ADH, so this is the exact opposite. This is in a patient who has too much ADH being secreted. Now, what's going to happen? Well, the collecting tubes now are going to respond to the ADH, and they're going to resorb all the water. So now you're going to hold on to water. You're not peeing it out. You're going to make a little bit of urine that's very concentrated, because that's what ADH does. It holds on to water. It adds water to your body, adds water to your body. So basically, you're going to be diluted. You're going to be diluted. You're going to be full of water. So you're going to produce a very concentrated urine because you're going to hold on to free water. So if I ask you, what's the sodium level when you're all diluted? It's going to be diluted too. Sodium level is going to be really low. Now, problem with all this holding on to water is you're going to swell. Now, if my hand swells, won't kill me. My brain swells, that will kill me. So that's the problem here with holding on to too much water. You're going to wind up with cerebral edema and potentially eventual herniation. Now, what's interesting to me is it's just the brain that swells. The rest of the body doesn't swell. But you're holding on to water. I know you're all diluted, but you don't swell up. You don't like get edema. And I was like, what's up? So the total body water is increased, but the blood volume is normal, and you don't get peripheral edema. So what's up with that? What's that lies over the brain? And then my physiology friend said, John, it's a sodium escape phenomenon. Okay, I don't know what that means. I have no idea what they're talking about. But for some reason, whatever, something escapes and they don't seem to get peripheral edema. I don't know why. Total body water's up, but they don't get peripheral edema. Interesting. All right, now let's go to etiology. Who is going to get too much ADH? Well, on the exam, here's the biggie right here. Malignancies. Malignancies. Small cell carcinoma of lung is notorious for this. I've also seen renal cell do it too, but for USMLE purposes, small cell of the lung. In fact, I often get a lot of emails, and I get emails like this. John, you're right. I was taking an exam, and on my one exam, I had 3 questions on lung cancer making ADH. 3 questions on it. So they apparently really like it. If one student got 3 questions on one exam, wow. So they really like small cell making ADH. Now, of course, there are drugs that can increase ADH. There's CNS problems that can do it, infections, trauma, anything that damages the stalk. If you damage the stalk, ADH can be released suddenly. So you can get sudden release of it. So a bunch of diseases can do it, but for the exam, I want you to have a small cell. Okay, now tell me. They're holding on to water. They're adding water to their body. So what's the #1 treatment? They keep adding more and more water to their body? Don't let them drink more water. Water restriction is your #1 treatment here. Don't let them drink more water. Because they're already you give them more water, they'll drink it and hold on to it. They'll hold on to it. Then #2, if that is not sufficient, you will add ADH antagonists. And these are new sexy pharmacology drugs. The Vaptans. Vaptan. Oh, they're so sexy. Vaptan. And I kind of like the name. This is for vasopressin antagonist. Little dyslexia in that last part. Antagonist. It's TAM, but antagonist, kind of dyslexically written there. So I kind of like it. Vasopressin is ADH, and this is antagonism. Antagonist ADH. I kind of like that. So Vaptan drugs, expect to see them tested on your exam. They're sexy. They work with the vasopressin, the aquaporin, very sexy. Now, another thing I know the board will do is opposites. What's the opposite of holding on too much water? Peeing out too much water. Diabetes insipidus. So what drug can I give the patient to create diabetes insipidus to pee out all this water? That'll like reverse this by peeing it all out. Well, I can give the patient a nephrogenic diabetes insipidus I can do it by giving them lithium, but that's going to give them neurologic problems. Now, we're going to give demeclocycline, because if we remember, demeclocycline was one of the 2 classic drugs. Come back here. Where is it? There it is. If I come back here, lithium and demeclocycline are 2 drugs that give me a nephrogenic diabetes. Again, I don't want to give somebody lithium unless they really need it, so I will give demeclocycline to cause diabetes insipidus. That's so weird. You're going to cause another disease to treat the disease. Cool. All right, but again, gold standard is water restriction. Vaptans would be second. And then third, you can use demeclocycline, especially if there's some chronic patient, they have lung cancer, can't cure it, patient's thirsty, they want to drink, so let's give demeclocycline. All right, now let's leave the pituitary behind. By the way, you guys still with me? Because my computer's lagging, that always makes me think I got cut off. You still there? Okay, good. Just want to make sure you're still there. All right, now pituitary's done. Now we're going to switch gears completely and go to the thyroid gland. Now, the thyroid gland is also controlled by the master control, right? The hypothalamus is really the one in control. It will stimulate the pituitary, so it's going to tell the pituitary to release thyroid stimulating. Thyroid stimulating is going to bind to its receptor, again through G proteins, and that will signal the thyroid to release thyroid hormone. So again, it's this TSH that stimulates the thyroid to release the hormones, T3 and T4. Again, lipid soluble, they're going to be bound to carriers, but it's the free fraction that we always care about. The free T4, the free TSA, that's the active component. That can dissolve itself right through the lipid membrane into the cell and bind to these receptors. These receptors in the cytoplasm, when they bind together, they'll go into the nucleus, they'll bind to the target DNA, and you'll get gene expression. Now, thyroid hormone, most importantly, is going to increase metabolic rate, give you a hypermetabolic state, and it's going to increase sympathetics. So those are the 2 major effects of thyroid hormones. Now I want to add one more. During development, thyroid hormone is critical for brain development. Critical. So we're going to see, oops, there it goes. Oh, I spelled it wrong. Close enough. We're going to see in a future slide, when a baby is missing thyroid hormone, their brain is not going to develop. So they're going to be severely retarded. So retarded they can't sin. They're so retarded they can't think evil thoughts. So they say, wow, this kid can't think evil? They're like Christ. So they call them cretins, cretinism. Cretinism is like when you have like iodine deficiency and the baby can't make thyroid hormone, so the baby's brain doesn't develop and they're severely retarded, called cretinism. Not cool, not cool. Don't want to see retardation in anyone, especially not babies, not good. All right, so again, what is thyroid hormone important for? For development, it's important for the brain, and then for the rest of our lives, it's important for metabolism and our sympathetic tone. Make sense? All right, now I got to talk about the diseases. We'll do it in a second, but first I want to do this. If the gland is the problem, for any endocrine, if the gland is the problem, we call it primary. If the gland is doing it, either hyperfunctional, hypo, it's called primary if the gland is doing it. What if it's the pituitary that's either stimulating the gland too much or not stimulating the gland? Oh, well, that would be called secondary. So in this case, it would be secondary hyperthyroidism or hypothyroidism. And then finally, what if it's the hypothalamus that's not stimulating the pituitary and it's not stimulating the thyroid? Well, that would be called tertiary. Tertiary. Okay, so again, if it's the gland that's causing the disease, it's called primary. No matter what gland it is, parathyroid, thyroid, adrenal, we call it primary if it's the gland that's doing it, either hyper or hypo. If it's the pituitary, it's called secondary, and if it's the hypothalamus, we call it tertiary. Make sense? So how would I know? How would I know, is it the thyroid? Let's say it's hyperthyroidism. Let's say the thyroid is making too much hormone, too much hormone. How would I know, is it the gland? Is it the pituitary? How would I know? Is it the thyroid making that hormone, or is it the pituitary telling the thyroid to make the hormone? Measure TSH. This is one of the most important tests we can do for hyper and hypo. get TSH. Because if the TSH is high, oh, well, that means the pituitary is telling the gland to make high hormones. Make sense? That's why you're hyper. But what if the TSH is low? If the TSH is low, and yet the gland is still making high hormones, now I know it's the gland that's causing the hyper state. Make sense? All right, that's very important. We'll do it again in a minute, but I just want you to remember that one of the key tests you're going to do here is the TSH, because that will tell us, is it primary, is it the gland, or is it pituitary or hypothalamus? Could be either one. So TSH is high, it's either pituitary doing it or hypothalamus. To tell those two apart, you're going to need an MRI or a CT. You want to look at the celiac turcica, you want to look at the hypothalamus with a CT or MRI to distinguish. Because I can't tell these apart. I can't tell these apart with TSH. So whether the hypothalamus is stimulating the pituitary or the pituitary is stimulating it by itself, TSH is going to be high in either case. I guess you could have measured this, but it's kind of hard to measure that because this is only So you really wanted a break, huh? You just kicked me out. I don't know what happened there. It just seemed to cut off. Weird. And I kept on talking. And I was talking and talking and talking. And I was talking to myself. All right. I don't know where I got cut off there. So I'm just going to just repeat and then we'll take a break because clearly the computer needs one. If you're hyperthyroid, if you have hyperfunctioning of the gland, is it the gland, the thyroid doing it, or the pituitary doing it? Or pituitary or hypothalamus? Which is it? I don't know. So get the TSH. The TSH will tell me, is it secondary and tertiary versus primary? If the TSH is high, well, that means that the pituitary or hypothalamus is stimulating the thyroid. So if the TSH is high, we know it's either secondary or tertiary, so get an MRI to distinguish between those. On the other hand, if the TSH is low, well, that means that the hypothalamus and pituitary are not stimulating the gland. The gland is making the hormones by itself. So that means it's primary for sure. So TSH tells me primary versus secondary and tertiary. To tell secondary and tertiary apart, you're really hard to tell. So really what you need there is you need an MRI or other imaging study to look at the two. I guess you could measure thyrotropin releasing hormone, but the problem is it's only present between the hypothalamus and the anterior pituitary. So you'd have to measure in the inferior pituitary side. That would be a tough thing to do. It'd be pretty invasive. So better to get an MRI than to do a sinus measuring this release of hormone. Make sense? It doesn't last very long. It only goes from hypothalamus to the anterior pituitary, and then it pretty much gets used up, destroyed. All right, I think that's a great place to take a break. We'll take a break, we'll come back, we'll talk about some thyroid, and then we'll be done for the day. See you guys in a little bit. actually half an hour number 3. We're going to do some thyroid now, very important organ. As you know, the thyroid is a very important hormone for metabolism. We like to keep our metabolism up. And of course for sympathetic function as well. In utero, very important for brain development. Now it's going to work through G receptors, G protein receptors, and it's going to stimulate cyclic AMP. That will stimulate the release of T3, T4. Goes across the membrane inside the cell, binds to the receptor, and that turns on gene expression. Now let's talk about what the thyroid looks like under the microscope. Well, if we remember from histology, we have these follicles that contain colloid, this pink material made of proteins. Particularly, it's made of thyroglobulin, which is the storage of our thyroid hormone stored. Here are the follicular cells. These follicular cells line the follicles. Out here are blood vessels. So when there's TSH, TSH is going to stimulate these follicle cells to take this thyroglobulin, break it into T3 and T4, and release it into the blood vessels. Here's our capillary here, here's another capillary here. So that's the job of these follicular cells, to reabsorb the colloid and release the thyroid hormones into the blood. Now, notice these little white spaces here. These are resorption vacuoles. So these cells are functioning. They're taking a little bit of thyroid, colloid, and releasing it as thyroid hormone. So that's what you look for. These little white things here next to the edge, those are called resorption vacuoles. They should just be small ones, because all the time you should be releasing a little bit, just sipping on some of this colloid and releasing it just slowly over time to keep your thyroid hormone level. Now, in between the follicles, so this is a follicle here, here's a follicle down here, another follicle over here, another one over here. Now, in between these follicles is a group or nests of these cells. They're not associated with colloid. These are called parafollicular cells. They're next to the follicles, they're in between them, they're in the interstitium. These parafollicular or C cells, they come from neural crest. They migrate here through the fourth pouch, so from neural crest to fourth pouch, and then they come in and they're going to produce for us calcitonin. That's their job, make calcitonin. So here they are, parafollicular C cells, they secrete calcitonin. Now I call it calcibonin. Calcibonin, because it helps calcium go from your blood into your bone. So it increases deposition of calcium into the bones. It also inhibits the resorption of the bone calcium by osteoclasts. So it inhibits osteoclasts. So that keeps the calcium in the bone. That's the job of your parafollicular C cells. Now, as I mentioned, TSH is going to act on the follicular epithelium, and those cells are going to convert thyroglobulin, which is the colloid, into T3 and T4, and they're going to release it into the bloodstream. So we have two different cells doing two different things. And later on, these will be very important, these parafollicular C cells, because they're going to become a tumor called medullary carcinoma thyroid. It's not very common, but it's very testable because it makes a calcitonin. That's also going to form amyloid. It's a very interesting tumor. So just some of these parafollicular guys. All right, now let's talk about the 4 major diseases we're going to see in the thyroid. As we mentioned, all the glands can have hyper states and hypothalamic states. Another thing that can happen in the thyroid is thyroiditis. In fact, when the thyroid gland gets inflamed, initially it can release hormone and you get hyper, and then it gets destroyed and you can go hypo. So thyroidism, or thyroiditis I should say, can give you hyper and hypo states, can give you both. And then finally you can have mass lesions. Tumors of the thyroid are very high yield. Papillary carcinoma, very high yield. So we're going to need to know those tumors really well. Now we're going to start out with hyper states first. Hyperthyroidism, hyperfunction. Another name for this is thyrotoxicosis. Thyrotoxicosis. It means elevated levels of free T3 and T4 because the free fraction is the active fraction. This is that's going to give you a hypermetabolic state and increased sympathetic tone as well. It'll give you both. Now, what's the most common cause of having high levels of T3 and T4? Well, it's usually a hyperfunctional gland. So the most common cause is going to be what's called hyperthyroidism, a gland that hyperfunctions. And that accounts for most cases. So you can use the terms interchangeably pretty much. So thyrotoxicosis, high levels of T3 and T4, are almost always due to hyperfunctioning glands, hyperthyroidism. But remind me, could you also have high levels of these hormones? because you took exogenous hormones? Could you just overdose on Synthroid? Could that give me hyperthyroidism? Yeah, I'm sorry, that gives me thyrotoxicosis, but it's not hyperthyroidism. Hyperthyroidism has to be coming from the gland. So that would be an exogenous thyrotoxicosis because you take exogenous hormones. So again, usually most cases of high levels of TT and T4 are due to hyperfunctioning gland, but not always. Not always. There's always got to be an exception, right? All right, now let's talk about diseases that cause hyperfunctioning. Okay, primary. Primary means it's the gland, right? It's the gland doing it. Gland making too much. Well, a classic one would be diffuse toxic hyperplasia, which is called Graves. And if you only learn one, this is the one to know. So when I say hyperthyroidism, you should think Graves' disease. It is the gland just making too much. It's an autoimmune phenomenon. Now, rarely, you can also have hyperfunctioning, or what they call toxic, multinodular goiter. One of those nodules can just get hyperfunctional. That's possible. Another possibility is adenomas. Adenomas of thyroid are usually non-functional. They don't usually make much. Every once in a while you get one that's hyperfunctional, we'll call it a toxic adenoma, toxic. So these are kind of rarer causes. So it's all about Graves. These are much lower yield. Now, what if you take a lot of iodine? For whatever reason, you're taking iodine supplements or something. Well, the more iodine you have, the more hormone you tend to make. So high levels of iodine can give you hyperthyroidism. And then what about a neonate? A neonate whose mom has Graves. Oh, well, if your mom has Graves, the antibodies will cross the placenta and they'll stimulate the baby. So the baby can get overproduction as well from the mom. All right, once they're born, they're good though. Now let's talk about secondary. Secondary means it's the pituitary or hypothalamus. It could be a TSH secretion pituitary adenoma. These are rare, and notice we didn't talk much about it, right? We talked about the adenomas, we talked about prolactinomas, growth hormone, we talked about ACTH. We didn't really mention TSH secreting ones just because they're very rare. But obviously, if you make TSH, you're going to stimulate your thyroid, you're going to get hyperthyroidism. That would be called secondary. Now, other things can also cause hyperthyroidism, but they're not really primary or secondary because it's not overproduction. A good example would be granulomatous disease of the thyroid. So if you get thyroiditis, you inflame the follicle, what's going to leak out? Hormone. Hormone's going to leak out, not because it's overmade, because of inflammation. It's just going to leak out, and you get hyper for a while. So thyroiditis, either granulomatous or lymphocytic, either one, can also give you a temporary hyperthyroid state during the inflammation. Just leak it out. Now, here's a sexy one. What if it's not the thyroid making the hormone, but it's your ovary? That's called struma ovaria. Do you remember that one? Struma ovaria, not strudel, not a German pastry. It sounds like a German pastry. It's an ovarian teratoma, which mostly has thyroid. So it's the ectopic thyroid that's making the hormone for you, so your gland can actually shut down because it's the ovary doing it all. And then finally, factitious. Somebody could be ingesting Synthroid. That can give you hyperthyroidism. Somebody's taking it. Maybe they're trying to overdose, or a kid taking their parents' Synthroid. Okay, but the one they're most likely to have in this other category is struma ovaria. Kind of sexy. By the way you pick it up is they're going to have hyperthyroidism. So I always think Graves first, but Graves is a goiter. It has a big thyroid gland. So it looks hyperthyroid. It looks like Graves, but there's no goiter. Check the adnexal region for a mass. If you feel a mass in the adnexal region, it's struma ovaria. All right, now we're going to focus on hyperthyroidism first in general. Then we're going to talk about Graves' disease in specific, because Graves is the major cause of hyperthyroidism, especially on exams, but even in real life. Hyperthyroidism, Graves, big cause. Now, hyperthyroidism has both hypermetabolic state, you're burning up, and also overactivity of the sympathetic, so high sympathetics as well. Now, for metabolism, you're going to be burning up, so you can't stand the heat because you're already hot. So this is the kind of person who's always going to make their apartment cold. They want the air conditioner on because they're hot. They're always burning up. They're fanning themselves. It's hot. So they turn the temperature down. And they also lose weight. Even though they're eating great, In fact, they're eating more because they're hypermetabolic. They're burning stuff like crazy. So they tend to eat more, but they still lose weight. Oh man, that would be awesome. I could eat all I want, but I still lose weight. That would be a great thing. The greatest weight loss program ever. Eat more, lose weight. Oh, great. Now, everything in your body is hypermetabolic. So the cardiac system is hypermetabolic, and that's the earliest and most consistent finding. They often present with tachycardia, rapid heart rate, palpitations. Doc, my chest is jumping out of my throat. Now, unfortunately, they're also at risk for atrial fibrillation, and that's very testable. Graves, hyperthyroidism in general, and atrial fibrillation. And then long-term, since the heart is working hard, you can get cardiomyopathies because it'll hypertrophy for a long period, but eventually you could dilate. You can get dilated cardiomyopathy long-term. That'll be a long-term complication of untreated hyperthyroidism. Again, remember, they often present with palpitations, tachycardia. Now, what about the neuromuscular system? Well, you got sympathetic nervous system overactivity. So you're going to get tremors, hyperactivity, emotional, like you'll be so liable, you have mood swings, anxiety, inability to concentrate. Yeah, not the urine this time, concentrate on material. Insomnia, you'll be up all night, you're hyper. Now, the four proximal muscles tend to get very weak, and they tend to lose muscle mass. We call this a thyroid myopathy. You're basically burning up your muscles, burning them up. Now, the eyes. Since the sympathetics are active, you often get this wide staring gaze. It looks like they're staring, wide staring gaze, because sympathetics are going to stimulate the tarsal muscle. So your eyes are going to be contracted, so they look like they're staring. In addition, the eyeballs are actually pushed forward. So it really looks like their eyes are bulging out of their skull because they are. You get what's called exophthalmos, also known as proptosis. And well, X means outside, right? So your eyes are protruding outside. Yeah, and the reason for this thyroid ophthalmopathy is the fact that behind the eyes, the fibroblasts get stimulated and they lay down glycosaminoglycans and proteoglycans, myxoid tissue. And that's very juicy. That's juicy, attracts a lot of water. So that juicy tissue will push the eyeball forward, and both eyes will actually bulge out. This is very common in Graves' disease. Graves' disease occurs. All right, so Graves' disease looks like bulging eyeballs because of the myxedema behind the eye pushing it forward. All right, now what about the GI tract? That's hypermetabolic too. So now you get hypermotility, you're going to get malabsorption because transit time, I mean, it's just rushing through there. There's no time to absorb. And you'll get diarrhea as a consequence. Things are just firing through. And of course, the bones. The bones are burning up too. So they start getting resorbed, you get osteoporosis, you get increased risk of fractures. So everything is hypermetabolic. The heart is working faster, the GI tract is working faster, the bone is burning up and breaking down, your muscles are breaking down. This is a hypermetabolic state. Now, the most common is going to be Graves. So we want to confirm this and make sure it is Graves. So when we see hyperthyroidism, first we diagnose that, then we look for etiology. So the way we're going to diagnose it is the first thing we do is a third generation or ultra-sensitive serum TSH. That is your first step. It is the most useful single screening test for hyperthyroidism, because if the TSH is decreased, if it's decreased, well, that means the pituitary ain't causing it. It's the gland doing it. That's primary. Think of Graves immediately. Primary. Now, on the other hand, if the TSH is increased, that's the pituitary or hypothalamus. So we got to check the MRI to look at the pituitary and hypothalamic area to see if there's like a tumor or mass there. So again, TSH is your first test because you come up with symptoms, you look hyper, you smell hyper. I'm going to know you're hyper. I want to know etiology, the cause. So get the TSH first. And of course, if the TSH is low, we're thinking primary. So we'll confirm this by just checking the T4 to make sure that it's increased. Just confirm it. So TSH tells me it's decreased, it's primary. I want to just make sure, so just check the free T4, it should be increased if you're hyper. Now, rare patients, the T4 will actually be in the normal range. Like, what's up? It should be high. Check the T3. because sometimes the T3 can do it. That's called T3 toxicosis. When T4 is normal, but T3 is high. Make sense? So they'll have free T4 levels that are actually normal or sometimes decreased, but the key is that T3 is high. Okay, so T3 can do it sometimes too. Now, in any case, I want to find out rheology. So to confirm that the primary case is going to be Graves', one of the things that can help you is doing nuclear imaging. You use radioactive iodine-131. This is called an uptake scan. Uptake. Now, I remember like this. The uptake tells me, is the gland on? Does it need the iodine? Is it working? Is it functional? Or is it off? If it's off, it doesn't need iodine, it won't pick it up. So basically, this tells me, is the gland on? Is it working? Or is the gland off? That's what the iodine uptake tells me. Is it on? Then it'll be pulling up iodine, it'll light up. If it's off, it won't be using iodine. It won't light up. Very helpful for determining etiology. So if it's Graves' disease where autoimmune, your gland is stimulated by antibodies and it's turned on, the whole gland will light up. The whole gland will be picking up the radioactive iodine and the whole thing lights up beautiful. So you'll see the whole thyroid gland lighten up like a Christmas tree. Whole thing, lighten up, lighten up, lighten up, lighten up. It'll all light up. Now, what if I do the scan and I only see that? Well, the rest of the gland is like, not only that, this is lighting up? That looks like a nodule, isn't it? Yep, if it's a nodule, now we want to think about a toxic adenoma. Adenomas are usually cold, usually non-functional, but every once in a while you get a toxic adenoma and it will light up like a Christmas tree on the scan. And then finally, what if the whole gland doesn't show up? It's like decreased, it's not working. Oh, the whole gland's not working, but you're still hyper? How could I be hyper if the gland ain't? Oh, it's inflamed. The gland is inflamed. So the hormone is leaking out. Gland ain't working because it's inflamed, but hormone's leaking out, that's why you're hyper. So again, if you see decreased uptake, but you have hyperthyroidism, it's going to be a thyroiditis. It's going to be one of the thyroidities. Make sense? So this scanning can really help me tell diffusely increased, that's Graves'. Diffusely decreased, that's thyroiditis. If I see a solitary node that's picking up, that's a toxic adenoma. Very helpful. All right, now a couple more words about Graves'. If this is the money, man. Show me the money. This is the money. Graves' disease. This is the most common cause of endogenous hyperthyroidism. Now there's a triad. A triad of features we're looking for. Number one, we want to see hyperthyroidism with a diffusely enlarged thyroid. That's called a goiter. Diffuse. Not nodular. If it's nodular, you'll think about multinodular goiter. But this is diffusely, smoothly. The gland is big, but it's smooth. I don't feel nodules in it. That's one of the key features. Hyperthyroidism with a diffuse goiter. I mean, it's huge. Neck sometimes enlarges. Number two, they're going to get myxedema. They get it behind the eye, and they get it in front of the tibia. So we look for it behind the eye. We call this infiltrative ophthalmopathy, where the stimulating antibodies stimulate the fibroblasts behind the eye in the orbit. And those fibroblasts get turned on and they lay down gas. So you get myxedema, and that pushes the eyeball forward. You'll see exophthalmos or proptosis bilaterally. Finally, the same fibroblast can get stimulated in front of the tibia, right in front of your tibia. So you get this localized infiltrated dermopathy where you get in front of your tibia, you get myxedema. So if you feel down on your tibia, man, you feel the bone, it's hard. It's hard. So this is going to be doughy. They're going to feel the tibia and they're going to say it feels doughy because myxoid tissue is juicy. It's very juicy, feels like dough, doughy. And again, non-pitting type of edema. Myxedema is non-pitting. So it feels doughy, but it won't pit. Like heart failure. Heart failure pits. This doesn't pit. So this is our triad. Hyperthyroidism with a goiter, plus bulging eyeballs, plus pre-tibia myxedema. This is our classic clinical triad for suspecting the diagnosis. Now, it's an autoimmune disease, so it's most common in the reproductive age, and notice 10 times more common in women. Men get it too, but most of this chapter is going to be women. Now, is there an HLA? Of course. It's autoimmune. Your immune system runs in the family. So HLA-DR3, that's the association for this one. Again, the board likes HLAs. They like B27, they like DR2, DR3, DR4. Those are the ones they really like. So B27, DR2, 3, and 4. Those are each of these associations that they like to test. Now, some people think that this is a spectrum between Hashimoto's thyroiditis, which is also an autoimmune disease, and Graves' disease. So Hashimoto's at the one end of the spectrum, Graves is at the other end of the spectrum. So they're both autoimmune diseases where the immune system attacks the gland. But in Hashimoto's, it destroys the gland and you go hypo. In Graves' disease, the immune system stimulates the gland and you go hyper. So again, they think that this is basically an autoimmune disease. If it attacks you one way, you get Graves. If it attacks you the other way, you get Hashimoto's. But they think they're both autoimmune diseases. Make sense? Make sense? Hold on, wait a second. I missed somebody asked a comment. My computer screen, I gotta blow it up so I can see. What about beta HCG? Does that cause hyperthyroidism? Gonadotropin, it can. It's not a huge trigger for hyperthyroidism. So it's something that has been associated, but it's not huge, and I can't imagine the board asking that. But yeah, there's other things that can also trigger hyperthyroidism. Graves is the biggie. All right, now, like Hashimoto's, we think these are both autoimmune diseases that are kind of similar, except one's destructive, one's stimulatory. Just like Hashimoto's, there are certain polymorphisms that we find in the inhibitory T cell receptor, CTLA4. Remember, if you inhibit your T cells, or so I should say, if you lose inhibition of your T cells, now your T cells can attack you. They can attack you because you're not controlling your T cells. So this may be a T cell regulation problem. Same thing for the PTPN22 gene. This basically allows your immune system to attack you if you have certain alleles. So this allele, these are very important for not just Hashimoto's, but Graves' disease as well. Okay. Yeah, DR3, it's not super high yield for anything else. Antiphospholipid sometimes, dosing sometimes. DR4 is the one with a lot. DR4 has so many associations. The other DR3 big one that I would know is diabetes. Diabetes. So diabetes and DR3. DR3. Okay, DR3, DR4. Okay, good. Other ones, nothing else super high yield aside from diabetes. All right, now let's talk about what you're going to find in the blood here. There are T cells involved, but there's also antibodies here too. So the antibodies make multiple different types of antibodies against the thyroid. The first one is called thyroid-stimulating immunoglobulins, and this is a very important one to look for to make the diagnosis. Because I don't want to do a biopsy of your thyroid. I want to look in the blood and make the diagnosis. So if I have the clinical triad, plus its primary hyperthyroidism, and you find these antibodies, this is going to cinch the diagnosis for you. Now, in the old days, they give a different name. So I'm going to take the different name just in case the board uses the old name for this. So I'm just going to put it here. They called it LACTs, which is long-acting thyroid stimulator. So LATs, this was the old name for, not cats, lats, oh boy, no, but LATs. LATs, long-acting, there you go, LATs. Long-acting thyroid stimulator, that's an older name for it. Makes sense, long-acting thyroid stimulator or thyroid stimulating immunoglobulins. Now what these do, they're gonna stimulate the thyroid, and the thyroid will now make high levels of T3 and T4. Okay, so it's gonna stimulate the TSH receptor, They don't destroy it, they turn it on, and the gland makes lots of T4 and T3. That's why you get hyper. Okay, so they turn on the follicle cells, they bind to the TSH receptor on the follicle cell, tell the follicle cell, hey, slurping up that colloid and start releasing it all as free T3 and T4. Okay, that's how they work. Now, we have another antibody called thyroid growth stimulating immunoglobulins. What they do is they cause the goiter. They make the gland enlarge and they give you the goiter. And then what's kind of like counterintuitive, they also have TSH receptor blocking immunoglobulins. What's up with that? this thyroid stimulating enzyme binds TSH and turns it on. You mean they also make antibodies that block the TSH? Isn't that kind of like lessen the disease? Kind of. So they can have some of these antibodies that block the receptor, which kind of like mitigates some of the symptoms. So it really depends on how much of these antibodies they have compared to how much of these. Okay, there's always more of these, but how much more? If there's a lot more, you get a lot more symptoms. If there's a little bit more, then you may not get much symptoms. So Graves can have a variable amount of expression of the disease depending on how much of these blocking antibodies. Wouldn't that be cool if we could figure out a way to make more? Make more of those blocking antibodies? That would be cool, because that would just really mitigate all of the symptoms here. That'd be cool. All right, now let's talk about some pictures here. Look at this woman. Doesn't she look like she's scared? So this is a combination of the lids being hyper-retracted from the sympathetics and the proptosis, the eyeballs being pushed forward by the myxoid tissue behind the eye. So that's classic. Now the second thing is look at her neck. She looks like a football player. I'm a football player. I mean, look at the size of her neck. I think you can almost see the outline of the thyroid. I think you can almost see it. I think you can almost see the gland. I mean, it's diffuse. There's no nodules, just diffusely enlarged. I mean, she looks like a neck of a football player, plus she's like scared or something. She looks like a deer in the headlights. Ah. So this is the classic features. So we got this proptosis plus diffuse goiter. Very, very classic features. Now, what about under the microscope? What if we remove this gland? What would we see? Well, it is thyroiditis, right? There's inflammation, there's lymphocytes coming in here, so the T cells are coming in. But what we're looking for is the gland being hyperfunctional. How do I know? The colloid. Where's the colloid? It all got slipped up. Here, no colloid. Here's some, here's some, here's some. But notice these resorption vacuoles are so big. These cells are slurping it up and releasing it into the bloodstream like crazy, like crazy. So some people call this a scalloping, like they call that a scalloping of the colloid. So look for pale colloid because it's being used up with a scalloped margins. Here's another good picture here. Look at this bubbling, this scalloping. Now remember, you should always have resorption vacuoles. If I go way back, way back here. Here it is. Notice. Oops. Computer's very slow today. Okay, there we go. Notice you should always have little resorption vacuoles, right? Little ones, kind of flat, not too big. So you should always have resorption vacuoles, but look at the size of these. These are huge. So that whenever I see that scalloping of the colloid, catch up. Whenever I see that scalloping of the colloid, that tells me this gland is hyperfunctional. It's hyperfunctional. And actually, these cells, these follicle cells, are actually enlarged as well. So these cells are bigger than they should be. There's more of them. They're proliferating because the TSH receptor and the thyroid growth antibodies are making them get big in more cells, and they're making them get hyperfunctional as well. So these cells are bigger. In fact, if you look over here, there's so many cells that they start making these polypoid structures. See this little polypoid structure hanging out in the lumen? Here's another polypoid structure. Look at this one. A little polyp. Yeah, they start getting these polypoid structures because there's just so many cells proliferating. No room. So they start tufting up into the lumen. Now, very important, there's no fibrovascular core. If there was a fibrovascular core, this would be papillary carcinoma of thyroid. So let's repeat. You see papillary structures in the thyroid, look to see if there's a fibrovascular core. If there's no core, then it's just hyperplasia. If there's a fibrovascular core in the middle, then that's a papillary thyroid cancer. So that's just the reason I brought out that there's papillae, but there's no cores to them. This is just hyperplasia. It's not cancer. Okay? So here are the things we're looking for. We're looking for diffuse hypertrophy and hyperplasia of the follicle cells so they can form these little papillary structures. We're looking for pale color with scallop margins. And we're looking for a lymphoid infiltrate because it is an autoimmune disease. You're attacking your gland, so there should be lots of T cells in there. Okay, now Graves' disease. How are we going to diagnose this thing? Well, again, we want to check the TSH initially. Check the TSH. When the TSH is low and you're hyper, we know it's primary. We know it's the gland. And of course, we want to confirm that you really are hyper by checking T3 and T4. So you're hyper and it's primary. You're hyper and it's primary. Now, to find out etiology, one of the things we can do is a radioactive iodine uptake. And we'll see diffused increased uptake. The whole gland is hyperfunctional, so the whole gland will basically light up. It'll just light up on the thyroid scan really darkly, and that tells me it's on. This gland is really active. That's why you're hyperthyroid, because the gland is turned on. Now, clinically, we'll look for our triad, hyperthyroidism with a diffuse goiter. We'll look for the enlarged, the protruding eyes, and we'll look for the pretibial myxedema. Now, this goiter gets so darn big, so big, that there's increased blood flow to it, so you can actually hear a bruit. You put your stethoscope on that giant gland, and you will hear a bruit. You'll hear the blood flow, the tremendous amount of blood flow going to that huge gland. Wow, I mean, that woman did look like she had a football player, right? So if you put a stethoscope there, you can actually hear a bruit in the gland. Wow. Now, treatment. There's two things we want to do here. We want to stop the thyroid function. We want to stop all the hormones. But we also want to control the symptoms, too. The tachycardia, the palpitations, they get arrhythmias. They get arrhythmias, AFib. So for the symptoms, we're going to do beta blockers. Okay, so true treatments here. First treatment is for the symptoms. Okay, so we use beta blockers like propranolol. What this is going to do is change the symptoms from it. It'll get rid of some of the tachycardia, some of the palpitations, the tremors, the anxiety, the sweating. So pretty important. We want people to feel better. So beta blockers for symptoms. But now I also want to decrease this hormone too. So there's two things we can do. Number one, we can use thioamines. Thioamines. So methimazole or propylthiouracil, PTU for short. Now these are going to decrease the thyroid hormone synthesis because they inhibit thyroid peroxidase enzymes. Thyroid peroxidase was needed to make T3 and T4. So that's a pretty good way of shutting down some of this production. Now another way you can do it is to ablate the thyroid, destroy it. If it's hyper, destroy it. So we could use radioactive iodine 131, and it'll be picked up by the gland, and it will destroy the gland. Or we could do a subtotal thyroidectomy. Remember, I don't want to remove all of the thyroid. It's hyperfunctional. I want to remove some of it. So we'll do a subtotal thyroidectomy, leave some of the thyroid behind so you don't have to take out much synthroid. Or radioactive ablation, hard to control. So the problem is sometimes after surgery, we took too much. Or the radioactive iodine, we killed too much of the gland. So what may happen? We may make you hypo. If we make you hypo, we'll give you Synthroid. We'll give you a replacement. Make sense? So I try not to do that, but it's hard to judge. How much thyroid should I take? How much radioactive iodine should I do? How much is it going to kill the gland? So sometimes you overtreat and you wind up with hypothyroidism. Actually, that's pretty darn common. Okay? So two treatments: symptoms and stopping the thyroid hormone. Cool. All right, now the next category is the opposite. We got to go hypometabolic. Got to slow down now. And this is kind of everything that's going to be the opposite of hyper. So your heart rate is going to slow down. You're going to get bradycardia. Your GI tract is going to slow down. You're going to get constipated. Your thinking is going to slow down. You're going to get very confused and trouble thinking. They often say they're in a fog. It's like, I can't think clearly, like in a fog. Maybe I had this before some of my exams. I feel like I'm in a fog sometimes. Maybe I have hypothyroid or something. So everything starts slowing down. So metabolism slows down. You barely eat, you pack on pounds. They gain weight like crazy. It's the worst diet ever. You eat little and you gain weight. everything slows down. And of course, the sympathetics will be decreased as well. So it's like the exact opposite of hyper. Okay, now if I'm missing thyroid hormone, I'm going to be missing my metabolism and my sympathetics. So this is a pretty fairly common disorder. Primary, in other words, gland destruction is much more than pituitary destruction or hypothalamic destruction, and increases with age. And of course, females much more than males. Okay? Now, causes of hypothyroidism. Could it be a developmental problem where I just didn't make it? Sure. It'd be a dysgenesis. You didn't make it. PAX6 is a paired homeobox gene, which is important for developing thyroid. So if I have a mutation in it, I'm not going to make my thyroid. I'm going to have hypothyroidism from the get-go. And same thing for some of these other things. FOXY1, what a great name, FOXY1. How about TSH receptor mutations? TSH receptor doesn't work. Your thyroid won't work. So there's these developmental problems that can give you congenital hypothyroidism. And remember, we need to check for this. So state-mandated screening. Every baby born, you're going to look for a lot of genetic diseases, lots of them. You look for alkaptonuria. You look for like a million cystic fibrosis. You look for a lot of different diseases genetically, and this is one of them. You gotta look for hypothyroidism because if the baby doesn't have thyroid hormone, the brain doesn't develop. You gotta get replacement right away. So very important to look for congenital hypothyroidism. Because in utero, mom will give you thyroid hormone, but once you're born, you're on your own. What else? We can have resistance syndromes where there's mutations to the binding proteins. Oh, but here's the biggie: post-ablative. Post-ablative. So in other words, surgeons destroying the gland. Radioactive iodine destroying the glands. Maybe radiation externally. Again, it's usually treatment for hyper states that makes you hypo. So this is a very important one. Another one that can happen is autoimmune. Autoimmune. We have a lot of autoimmune diseases that can attack all your endocrine glands. Here's a biggie: Hashimoto's thyroiditis. This is an inflamed thyroid that basically gets destroyed by the immune system. So you wind up hypo. Now I put the asterisk there because this one is going to have a goiter because it's inflamed. Goiter. So post-ablative, the thyroid's gone. No goiter there. But Hashimoto's, you're going to have a big thyroid because it's inflamed. Now another problem is iodine deficiency. That will also have a big goiter. That's only common though in areas that don't have iodine. In America, we have iodinized the salt. So it's going to be somewhere like Central Africa. They're away from the sea because sea salt has iodine. Maybe up in Nepal, up in the Himalayas, away from the sea. So the Himalayas, away from the sea level, or Central Africa, away from the ocean, where the salt has iodine. Yeah, so that's our iodine deficiency. It's pretty rare. How about some drugs? Drugs can do it. Drugs can mess up your thyroid. What else? Congenital biosynthetic disorders, where you can't actually synthesize the hormone. So if I can't synthesize the hormone, well, then I'm not going to be able to make much thyroid hormone. And the gland will get big. It will get big because it's trying to work, but it just can't make it. Now you can also have secondary, these are pretty rare. You have some sort of pituitary damage, panhypopituitism, maybe due to a tumor or mass effect, and of course, hypothalamic failure. These are both pretty darn rare causes. So again, think of surgeons destroying the thyroid gland, and think of Hashimoto's thyroiditis. Those are the two biggies. All right, now clinically, you don't want deficiency in utero because you can get cretinism. This is Christ-like. Cretins are like Christ. They're so retarded, they can't think evil thoughts. They're like Christ. So hypothyroidism in infancy and early childhood is going to affect the development of the brain. Now, number one, these kids will have a goiter, but they're going to have severe mental retardation. That's why they called them Christ-like. They couldn't think evil thoughts because they're so darn retarded. Now, thyroid hormone is important for bone growth, so they're also going to be very short too. They're going to be dwarfs. So they're going to be dwarfism and they're retarded. They get very coarse facial features. They often have a protruding tongue. That's very characteristic as well, and they often have umbilical hernias. Now, the causes of having thyroid hypothyroidism in utero or early neonatal life is usually iodine deficiency. So again, not common in America, but if you go to other areas where they have malnutrition, you might be able to see it. It can also be genetic defects in thyroid hormone synthesis. That's why we screen every baby for this, part of the neonatal screening test. Okay, so we always screen for this, because if you diagnose it early, I can give replacement hormones. All right, and again, cretinism is very infrequent nowadays because we're supplementing our salt with iodine. So it's very rare to see this. You have to go somewhere where they don't have iodine and salt, somewhere away from the sea. Now, another problem with all hypothyroidism states is the fibroblasts undergo dysfunction and they start producing a lot of gags. You get myxedema. And that occurs with hyper states, we just saw Graves, but also occurs with hypo states too. When the thyroid is not functioning properly, the fibroblasts, they kind of lay down gags for some reason. Now, this usually occurs when you have hypothyroidism in older children or adults, when that older usually occurs. And you're also going to see slowing of physical and mental abilities. You're like in a fog. You get fatigue, you get apathy, you get sluggishness. As I mentioned, you get constipation. You tend to put on weight because you're hypometabolic. You have decreased cardiac output. Now, the myxedema is very characteristic. It can occur anywhere, but not pretibial. Pretibial and behind the eyes, that's Graves. Pretibial and behind the eyes, that's Graves. They get myxedema in their face, so they get puffy face, very puffy, rody face. In the throat, they often get like changes in their voice. The tongue, it's one of the causes of macroglossia, the giant tongue. Pretibial area is not common. If you see it, it's usually most common with Graves' disease. Okay, so I said it doesn't occur here, but when you think pretibial, think Graves. It's usually in the face, the tongue, the hands, and the feet. That's usually what we see with hypostates. Now, this is very characteristic. They are hypometabolic, so they're cold all the time. They put the thermostat up to like 90 degrees. And I came from college, and I walked in the house, it's like a sauna. I'm like, Mom, it's like a sauna in here. She goes, no, I'm cold. I'm like, Mom, I don't think so. I took a look, it's like 90 degrees. The thermostat says 90. I'm cold. It's like, oh, Mom, you got hypothyroidism. And I went back to college. 2 weeks later, she calls me, John, you're right. I went to the doctor. I have hypothyroidism. I was in college and I diagnosed hypothyroidism. So remember, cold. And I also think all women have mild hypothyroidism. Why? Because they're always cold, right? Gentlemen, they say, I'm cold. And you're like, I'm not cold, but she's cold. So either women have borderline hypothyroidism or they're just testing us to see if we're gentlemen. Are we going to put our arm around her and warm her? Are we going to offer our coat? Are we gentlemen or not? Not sure. Maybe it's a combination of both. But I don't know. Women always seem to get cold before I do. I don't know. It's weird. Right? I know they want to see if you volunteer yourself. Or yeah, maybe they just want to steal our shirts maybe, or they just want our bodily warmth. They want us to take care of them. There's nothing wrong with that. That's all good. All right, now, another thing that often happens when you're hypo is the cholesterol goes up. The LDL goes up. So that's not good. That's not good. You're going to get atherosclerosis. So hypothyroidism can increase risk of atherosclerosis. Now, for laboratory, very important clue. Unexpected increase in body weight, or suddenly your cholesterol starts going way up. It's one of the things you should think of. So again, suddenly I'm putting on weight. I'm not changing my diet. I'm not eating more. It wasn't the holidays or anything. I'm just putting on a lot of weight and I'm kind of sluggish. That's when you think of it. Or when the cholesterol goes up. And again, they never had high cholesterol before. Again, what we start with TSH, most sensitive marker. It's increased if it's primary. Now, I want you to think about that. If the gland fails, the pituitary is going to be like, come on, work. Come on, we can work from home. Come on, you got to work. You can work from home, right? It's not working. So if TSH is increased, that means the pituitary is fine. It's the gland that's not responding. The gland is not following orders anymore because it's destroyed. Again, check to make sure the T4 is decreased. That will confirm there's hypothyroidism. Okay, so 3 T4 low. Cool. All right, now, the number one for you is Hashimoto's. But you know, these are pretty important diseases. Maybe I'll just do this one and then we'll end, because there's a bunch of hypothyroid, but I'm just going to do this one and end. So this is the most common cause of primary hypothyroidism if you exclude surgeons and radioactive iodine. Because the number one cause of hyperthyroidism is surgical ablation or radioactive ablation. So if we exclude surgeons, this is the number one cause of hypothyroidism due to the thyroid not working. Now there's another name for it. Since T cells are coming in to destroy the gland, they often call it chronic lymphocytic thyroiditis. That's what they call it, chronic lymphocytic thyroiditis, Hashimoto's. Now, it's the most common cause of hypothyroidism if you exclude iodine deficiencies. So, if you're not in an iodine deficient place, and you got to exclude surgeons too. Now, it's an autoimmune destruction of the thyroid gland. Now, initially, when the gland gets inflamed, hormones going to leak out. So, when they first get it, don't be surprised if there's a little hyperthyroidism for a short period of time, maybe a few weeks. They'll get toxic. That's called hashitoxicosis. So let's draw a diagram here. Here is your thyroid function over time. Okay, you start out euthyroid, normal thyroid function. Then you get this disease, you're going to go hyper. You're going to go hyper for a few weeks. As the gland gets inflamed, thyroid hormones leaking out, you go hyper. But then the gland gets destroyed. So now you're going to drop down, you go back to euthyroid, you keep dropping, and you go hypo for the rest of your life. Okay? So notice there's a period of hyper. There's a period of hyper, short-lived, couple weeks. Then the gland gets destroyed, you go back down to you, and then you keep going down to your hypo for the rest. You're going to need Synthroid for the rest of your life because you destroy the gland. Okay? So initially hyper, and then you get this gradual onset of hypo for the rest of your life. Now, I asked my mom, Mom, you're hypothyroid? Really? What was the disease? She goes, I don't know, but I'm turning Japanese. I was like, what do you mean you're turning Japanese? That might be cool. Japanese are awesome. I got Hashimoto's. Actually, she said, I got Quasimodo's. I was like, Quasimodo? You mean, she thought it was Quasimodo. She Googled it, and she saw the guy with the humpback and the big eye, and she thought she was going to die. I was like, no, it's okay. It's just hypothyroid. Take your Synthroid, you're all good. She thought it was Quasimodo. So please be careful. For you and me, Hashimoto thyroiditis. Thyroid's not working, take your Synthroid. You're all good, take your Synthroid. Not a big deal for you and me. But the rest of the world, when they hear you have Hashimoto, that doesn't sound good to people. Then I put that sounds Hashimoto, it sounds like Quasimodo. So make sure you explain to your patients, it's not a big deal. It's not a big deal. You have beautiful treatment for this. You're not going to get a humpback. You're going to be just fine. These Disney movies, Quasimodo, or The Beauty and the Beast. Did you see it yet? Maybe you went out and saw Beauty and the Beast this week. Is that what you did for fun? Did you see it? I heard it was really good. Oh, we have a fan. We have a fan. Is that because of Harry Potter? Wow, okay, I guess maybe I'll have to see it now. I'm a Harry Potter fan. I'll have to go check it out. Cool, I'll have to go check it. All right, now, Hashimoto's thyroiditis, well, it's most common in women in the reproductive age, but usually late reproductive. So this is like the end of the reproductive life, late 40s, 50s, 60s, the end of the reproductive life. And again, females, much more common than males. Males can get it too, it's just rare. Now, when this gland is inflamed, it's going to be big. So we're going to get a goiter, a painless goiter. So kind of like Graves, you get a goiter, but it's like Graves, but this is hypo. Now, if you removed it, which you don't do anymore, but in the old days when they took it out, they would see an intense lymphocytic infiltration, germinal center formation like crazy. These T cells are coming in, these B cells are coming in, they're making antibodies, they're destroying the gland, B and T cells. Now, when the follicle cells get injured, they swell. They get bigger and pinker. This is called Hürthle cell change. This is when the follicles become basically larger with abundant pink granulocytoplasm. So it's just a big pink follicle cell, Hürthle cell. Now for your exam, I want you to Hürthle cell, Hashimoto, Hürthle cell, Hashimoto, Hürthle cell. But is Hürthle cell only seen with Hashimoto's? No, other things can do it too. But when you see it on the exam, think Hashimoto's right away. So lymphocytes coming in and follicle cells getting big and pink, Hürthle cell change. These are the classic features. Now, why is your immune system attacking yourself? Again, you got certain polymorphisms where your T cell regulation is abnormal. You got CTLA and PTPN22 genes that are supposed to inhibit T cells, but in you, they're not working. So your T cells are now attacking your cell. Again, these are the same alleles of Graves. Same alleles of Graves. So we think these are the same diseases, except they're just different immune attacks. One turns your gland on, one destroys your gland. Okay, now here's just a nice little diagram. Here's the normal follicular thyroid epithelium, nice follicle cells. Now, for whatever reason, your immune system loses tolerance of yourself, and you start making antibody against your own thyroid. Now, inside the thyroid, there's what's called thyroid peroxidates, and that's important for making the thyroid hormone. So in these microsomes, these little vacuoles, there's thyroid peroxidase, and you're going to start making antibodies against that. In addition, you're going to have cytotoxic T cells. They're going to come in, and they're going to come in and try to attack these follicle cells, so they start getting injured, they start getting damaged. So that's type 4, right? Type 4 hypersensitivity, T cells coming in. What else? We have T helper type 1 cells that will make interferon. So now macrophages will come in, and the macrophages will try to damage as well. They'll release all their chemicals, try to injure. So again, this is clearly T cell mediated, either cytotoxic or CD4 mediated through a macrophage. And then of course, B cells are involved here too. They're going to make antibodies against thyroid antigens like thyroid peroxidase, anti-thyroid peroxidase, and other anti-thyroid antibodies as well. And these antibodies can come and coat the cells, and now natural killer cells will come in and kill. They'll come in and kill. So antibody-dependent cytotoxicity as well. Now again, the antibodies are type 2. Right? That's a type 2. Antibodies against the thyroid, that's a target, a thyroid. So we have a combination here of type 4, where the T cells are directly attacking, and then we have type 2, where you're making antibodies that are going to play a role in damage here too. Now, these anti-thyroid antibodies are found in approximately 50%, and they're very helpful for making diagnosis, because I don't want to biopsy your thyroid unless I have to. So we don't usually need a biopsy anymore. We just look for these antibodies in your blood. So that's happened to my mom. I was like, Mom, how do you know you have Quasimodo's, Hashimoto's thyroiditis? How do you know? He said, well, I started getting tired. I was lethargic. I was cold. I couldn't think. And then I went to the doctor because you said you have hypothyroidism. I went to the doctor, and sure enough, he said, I have hypothyroidism. He took some blood, and he said, I have TPA. And I was like, TPA? Oh, anti-thyroid peroxidase antibodies. When you see these, they're diagnostic. So you better get these in your memory bank here. Hypothyroidism with anti-TPA antibodies. This is going to help you with your diagnosis. I don't need to do a biopsy now if I find these antibodies. Now you also have anti-thyroid globulin antibodies too, but they're not as diagnostic. We want to look for the TPA, anti-thyroid peroxidase. That's how they diagnosed my mom. Okay, so anti-thyroid. By the way, I asked her, I said, Mom, was there a time when you were hyper? And she goes, yeah, for like a month. I was staying up all night. I was losing weight without trying. I was getting things done, baby. I was pooping like crazy. My VI system was working. Everything was great for about a month. And then I went hypo. See, people don't complain when they're hyper. When they're hyper, they're getting stuff done. They're pooping great. They're staying up all night. Their focus is great. People don't complain when they're hyper. They complain when they go hypo. In fact, I wish I was a little hyper. A little hyperthyroidism never hurt anybody. It's all, well, it will give you osteoporosis. It'll burn it down. It will make your heart work harder, so I guess that's not good. But being a slight hyper would be good. A little hyper. Never hurt anybody, a little hyper. But yeah, she went hyper for a while, then she went hypo because the gland got destroyed. And again, this is the most common non-iatrogenic, non-iodine deficiency cause of thyroid. Now, it presents as middle-aged females, just like my mom, with painless thyroid enlargement. And just like Graves, it's symmetric both sides and very diffuse, a diffuse goiter, just like Graves, but Graves is hyper, this is hypo. Under the microscope, you'll see the lymphoid infiltrate with germinal centers and Hürthl cells. So take a look at these follicles. They're follicles with germinal centers, beautiful germinal centers, follicles. And then notice these cells, like hard to see, but they're big and pink. I can't see it from this map. I'm a pathologist, so I can't see it. I gotta go closer. But anyway, these thyroid cells are really pink if you compare it to the normal picture. They're really pink and big and juicy. That's Hürthl cell change. Now, when you first get it, thyroid hormone's leaking out. So initially, the free T3 and T4 go up. You're actually hyper hashimotoxicosis for a little while. Now, if the hormone's leaking out, you're hyper, what's the pituitary going to, the pituitary's going to say, you don't need to be hyper, negative feedback, TSH will go down. And if you do a radioactive uptake, it will be decreased. So they look hyper, but the gland, it's not hyperfunctional, it's just leaking out. So the gland is off. The gland is off. It's inflamed, it's off, but you're hyper because it's leaking out. And the pituitary says, I'm not going to help, I'm not going to make any more. Let's stop. Let's stop stimulating. Now, later on, the gland gets destroyed. When the gland gets destroyed, now you go hypo. Now you're hypo. When you're hypo, now the pituitary is like, come on, gland, work, work. And now the TSH will go up. Now, radioactive iodine still off, still off. When you have thyroiditis, glands don't work. So it's off for thyroiditis. Okay, so hyper to hypo. First, you'll have TSH that's low, and then TSH eventually goes up. And this is usually when they come and get diagnosed. Last thing you need to know, and I'll let you go, is once you get one autoimmune disease, you're going to get others. So watch for other autoimmune and endocrine disorders. And if your immune system doesn't work, you can get cancer. So this is important. I had to watch my mom for lymphoma. Which one? Marginal zone, which is a B-cell non-Hodgkin's lymphoma. Remember the rule. Whenever there's inflammation, suddenly you see a lymphoma, you call it marginal. If it's in mucosa, you call it multoma. But if it's in lymph node, you call it marginal zone. So marginal is the one you pick whenever there's inflammation, like H. pylori inflammation, chronic hepatitis C, you get splenic marginal zone lymphomas. So hepatitis, H. pylori, Sjogren syndrome, Hashimoto's, these are all at risk for marginal zone B-cell lymphoma. Feel good? All right, now we can go watch Emma Watson. And then when we come back, we'll talk about another thyroiditis next time on Thursday. We'll talk about 7Q. All right, great day. I'll see you guys. Have a good week. Now I have to watch the movie. Now that you put it in my head, I gotta go watch it.
But hopefully someone stuck around to hear that.